1 minute. Has Dr. Sadhana?
Yeah, stop the recording.
Dr. Sadhana Gupta, good afternoon.
Good afternoon, sir. How are you?
I'm good.
Good to see you.
Yeah. I think it's 4 o'clock, so let us start.
Yes, sir, yes. Shall I start the recording?
Yes,
Sarita ma'am will join in between, sir. Okay?
Okay.
Sarita Baliram ma'am, yeah. For welcome.
Okay.
Sir, you can start, sir.
We'll have Dr. Sarita to start the welcome.
No, you can go ahead, sir. And Sadhana Gupta madam is there, so
Okay,
just
fine.
invite her.
Good afternoon, everybody. Good afternoon, everybody.
Good afternoon.
Today's our third day of the Poxy ICUG certificate course on oncology. And I must put it on record that we have more than 750 students or candidates who have joined in for this course, which is an overwhelming response that we have. This is our third day, and in the beginning, let me thank Dr. Parag Biniwale, the chairman of ICOG, and Dr. Sarita Bhalirao, the secretary of ICOG, for uh, having this program on oncology. Today, to start with this program and to inaugurate this, the third day, or to start the third day's proceedings, we have none other than Dr. Sadhana Gupta, who is the vice chairperson elect of ICOG. So I request Dr. Sadhana Gupta madam to say a few words before we go ahead and start with our program.
Thank you, Dr. Harshad, and my regards to all ICUG office bearers, Chairperson Dr. Parag Biniwale, Secretary Dr. Sarita Bhalirao, Dr. Sheela Mani, and Dr. Ashok Kumar. And these certified courses are our USP of ICUG, and all over the country, people look forward to these courses. Hearty congratulations to Dr. Sarita Bhagya and today's Dr. Harshad Parsnis, who has been the exemplary worker and the leader in the field of oncology in those time when the gynae oncology was not so popular. Now it has gained a lot of respect. We have the DM gynae oncology, and this is the way forward when the India and the South Asia is going to have the maximum burden of the cancer, which includes women and the gynecological cancer as well. Dr. Rakhi, Dr. Ushashi, and Dr. Litika Reddy are coordinator, and we really appreciate your great effort. These programs take a lot of effort to have the best faculty who are expert and who are having the experience, so that the knowledge and the skills is being shared to all over countries, our participant. Today, Dr. Harshad and Dr. Likita has made a very well-crafted program, and we really congratulate that the intricacies of endometrial malignancies and the first visit the gynae have, and when we do ultrasound, and we are just taken aback when we find cystic and the thickened endometrium, and the correct interpretation, correct imaging technique, and the current advice. This is the role of every gynecologist, so that people are not on long-going hormonal therapy. Then they go for the biopsies and the other confirmatory thing. Then the second part is very, very important: surgery, radiation, and targeted therapy. So I think our esteemed faculty, a lot of total radical change in our understanding with molecular basis, with genetics, with immunohistochemistry, and we all must be aware that what are recent advances so that the patient can be best cared of. And vulvar cancer is something which we have a lot of issues, because from biopsy to management, there are a lot of dilemma, and we are more elderly population we are having, and we are more likely to have it because it is the age, the disease of the geriatric age group. So we heartily thank every faculty who has given their time to share their knowledge and expert, Dr. Anjana Chauhan, Dr. Samar, Dr. Shalini, Dr. Rohit, Dr. Yogesh, Dr. Bhushan, Dr. Chetan, and Dr. Dipanvita Banerjee, and all the chairs who will be giving their pulse of wisdom. So we welcome you to the ICOG, and ICOG secretaries there, because we all have to assert, be a fellow and member of ICOG. The next ICOG fellowship will be awarded in Delhi and then in August 2026 at Bengaluru. So if you are not still fellow, please fulfill your credential and apply for ICOG fellowship and be a member of the great organization. Thank you very much.
Thank you, Dr. Gupta. The program today that we have actually made is basically, we have 3 sessions, out of which 2 sessions will be on endometrial cancer, the first and the second. The first is more to do with diagnosis, and so we have evaluation of postmenopausal bleeding by Dr. Anjana Chauhan. Then we have role of imaging and its importance and how exactly to go ahead with it by Dr. Samar Gupte. We have molecular classification by Dr. Shalini Rajaram, and then the new FIGO classification staging. Now, this is very important, and because this is how we are going ahead today by Dr. Rohit Ranade. Then the second session will be basically on what is, once you have diagnosed cancer, what is going to be your treatment, whether it is surgery, whether it is radiation, or whether it is chemotherapy. And in chemotherapy, we have this targeted therapy which has come up. So we have Dr. Yogesh Kulkarni, Dr. Bhushan Zade, and Dr. Chetan Deshmukh who are going to be speaking here. Then the third session is on basically management of vulvar cancers or vulvar pre-invasive lesions. So we have the first part will be on management of the cancer part, and the second will be more of the lesions, that is the pre-invasive or the vulvar lesions, some of whom might be benign and some who might be precancerous. So we need to identify them. It is a rarity to see vulvar lesions in the western part of the country more than the eastern part. So I think all our students need to be attuned to that. So with this introduction about the overview of the program today, let me ask Dr. Likita to start the first session and
Sir,
call upon the chairpersons.
Sir, Sarita madam had joined just for will comment this. Yeah.
Yeah. Hi, Papa. Harshad,
Hi.
sorry, I just got a little late, but I'm very happy to be here and I welcome all of you. And I think that it's been a fantastic last 2 days. As Madam Dr. Sadhana Gupta said, we had a great 2 days, and I'm sure today is also going to be very, very exciting. A big thank you to Dr. Sarita Shamsundar, Dr. Bhagya Lakshmi, and Dr. Harshad Parasnis for all the efforts that they put in, right from getting the topics, getting the speakers, and confirming everybody, and great coordination by Dr. Raki, Dr. Usha Shri, and today Dr. Likita is going to do the coordination. So all the very best, and look forward to seeing all of you in Delhi at AICOG. Thank you.
Likita, let us start with today's program.
Yes, sir. Good afternoon, everyone. We shall start with the session 1. The topic is the chairpersons of this first session are Dr. Colonel Bidon Roy and Dr. Suchita Dabadkar, ma'am. And the first topic will be by Dr. Anjana Chauhan, ma'am. Ma'am is a consultant gynec cancer surgery with more than 25 years of experience. We shall start with the presentation.
You can see my slides? Yes, ma'am.
Yes.
I'm just doing full screen. Yes, ma'am. I just want to thank the AICOG team for inviting me for this talk, especially Dr. Parag Bhai, Dr. Sarita ma'am, Dr. Harsha, who is a very good friend, and to invite me for a easy talk, but is a very complex because it covers many things, postmenopausal bleeding. Now, evaluation of postmenopausal bleeding is very important because last 30 years we have seen this increase in the lifespan of the women. and women live more 30-35 years after menopause, which was not there before 50 years. So this problem also is evolved. And what is happening, a woman has equal, her life is divided between menopause and premenopause of reproductive age, and now she's into menopause. So these all problems are evolving, and they are becoming more and more complex, and it is very important to diagnose and rule out cancer, particularly in this particular group. So what is postmenopausal bleeding? Episode of bleeding which is occurring, what we can say, 12 months or more after a menopause has set in. This is a common problem. 10% occurs after 10% of the women over the 55 may have this problem. 90% are benign cases, but there is no association of pattern of bleeding and malignancy. Even a small spotting can have a malignant tumor, and heavy bleeding will not have and have a malignancy. So all the women, irrespective of the bleeding pattern, has to be investigated. Now, coming to the causes of postmenopausal bleeding, it starts from physiological to pathological. All type of causes are there in menopausal bleeding. If you see vaginal atrophy, decreased estrogen leading to thinning of the vaginal skin, and pale vagina may bleed on contact, especially if they are not sexually active and they attempt sexual active later in their life, then it is a very common problem, and hence history is very important. We have seen many women, no cause found, and ultimately it comes out to be a postcoital bleeding. Infection, vaginitis is very common because of the thinning of the vagina, low estrogen, the infection sets in, and especially if she is diabetic, then even a small rise of diabetes, she may end up in infection and postmenopausal bleeding. Endometritis, pyometra, hematometra is very common now because we have lots of cesarean section, so the cervix is not dilated. And what happens, this women, the os is stenosed in the menopause because of the lack of estrogen, and even a small spotting, that bleeding which occurs, it is collected in the uterus, and women think she is menopausal, but later on when it may come as a postmenopausal bleeding. So all these factors are seen. One has to evaluate properly and find out the cause and treat accordingly. All has different treatment. There is no particular treatment for one cause. Postmenopausal bleeding, you have to find out the cause and treat accordingly. Estrogen therapy, if she's an atrophic vagina, she use estrogen, she may land up in spotting. Injuries, like I said, direct trauma, decubitus ulcer, especially having prolapse or very lax vagina or lax vulva, she dry vagina, vulva, and especially in obese women, they cannot see their private part, and whatever bleeding occurs, they assume it is a postmenopausal bleeding. Postcoital tear, radiation, post radiation, these all things can happen in menopause. Endometrial hyperplasia is a very common cause, and basically our focus for postmenopausal bleeding is to find out hyperplasia to rule out endometrial cancers. Malignant causes starting from cervical cancer, endometrial cancer, vulval, vaginal, fallopian cancers all may present as menopausal bleeding. Benign causes like cervical fibroid, uterine fibroid may bleed during after menopause, and they may come as postmenopausal bleeding. Hormone producing tumor, whenever there is an ovarian mass and bleeding, one has to think of hormone producing tumors like granulosa cell tumor, thecal tumors, stromal tumors, ovarian fibromas, all may cause bleeding. So we have to evaluate, we have to have a proper sonography when you do a menopausal evaluation, postmenopausal bleeding evaluation, and you have to look for ovarian masses. Large size tumor, especially when there's a huge fibroid, cervical fibroid, they get infected and they have increased vascularity, and they may present as bleeding, and we can call them as misfit tumors, but they may present as postmenopausal bleeding. Dysfunctional uterine hemorrhage, that may occur in 10% of case. There is an, what we say, reawakening of ovarian function. This is a one time episode, and you may see a follicles in a woman, but such things are also been noted in having a postmenopausal bleeding. Hemorrhage from other causes like bladder, urethral caruncle, papilloma, carcinoma of bladder, hemorrhoids, fissure, carcinoma of rectum, all may present as postmenopausal bleeding, especially if the women is not able to look into a private part, she will assume that is a bleeding from the vagina. Drugs, anticoagulant, tamoxifen, herbal drugs. Now there are so much herbal drugs for youth are coming up. These are probably hormone secreting herbal natural herbal drugs, and they may cause bleeding. Hormone replacement therapy. Anticoagulant is very common after the age of 50, which has been prescribed as a prophylactic, and women having atrophic vaginitis, atrophic endometrium, if there is an infection and if she's on anticoagulant therapy, she will have bleeding. She may present as postmenopausal bleeding. Systemic condition like leukemia, blood dyskeratosis may also present as menopausal bleeding. So menopausal bleeding and HRT, if you look in, it is a common occurrence. Once you start hormone replacement therapy, is not unusual. Usually such bleeding is lighter than the menstrual bleeding and should stop within 6 months. If it doesn't stop, then she definitely warrants what we can say investigations. When should you evaluate endometrium for and postmenopausal bleeding? So whenever a woman coming on HRT, if she develops bleeding after more than 1 year, she warrants investigations. Any woman, she is amenorrheic for 1 year and after 1 year she is having bleeding, then you have to investigate. Any postmenopausal woman on hormone replacement therapy for 6 months and after 6 months she is having bleeding, you have to evaluate. Previously amenorrhea woman on HRT now begins start bleeding. These all condition you have to evaluate endometrium for endometrial hyperplasias and endometrial cancers. You have to evaluate. And first of all, you have to rule out the other causes of postmenopausal bleeding. Then you have to evaluate the endometrium for the cause of postmenopausal bleeding. Tamoxifen use, the 2 to 3 fold increase in endometrial cancers. So such women should be kept under surveillance. Now, looking into the percentage wise, you will see endometrial cancer, it is only 10%. There are other causes also. So you have to rule out other causes before proceeding for the treatment, because only 10% cancer. So that goes to the oncologist. Other all type of etiological factor, a normal gynecologist can treat them. And so you have to evaluate properly before sending him to an oncologist. Don't rush to send all the patients for the cancer treatment, or but fear them of cancer. So main aim, how do you evaluate postmenopausal bleeding woman or a patient? Then main aim is to find out and exclude cancer. Start with a detailed history. I said take the history of sexual history, then take the history of anticoagulants, take the history of injury. When one of the woman we seen, she had put some, what we can say, a rod in her vagina and she came with postmenopausal bleeding. So such type of histories are very important. Tamoxifen, hormone therapies, breast examination as usual should be done in each and every woman, and abdominal to rule out masses to see, and PV examination to rule out cervical cancers, vaginal or polyps. Pap smear is an indirect way we do for each and every woman for cervical cancer. By or HPV test, whatever you are doing at your place, by minimal examination to see the uterus and over adnexal masses. If you see an abnormal pap smear in a menopause, you have to rule out. If they are having LCL, HCL or SCUS, you have to rule out cervical cancer. And especially in the such cases, colposcopy is not helpful, so you have to go for cone or lip biopsy. When you see endometrial endoglandular cells in the pap smear, you have to rule out. Further investigation is must. They may be having agas or atypical glandular cells or endocervical or adenocarcinoma in situ type of cell or adenocarcinoma. All these patients need to have a DNC or hysteroscopy or a deep cone biopsy to rule out either cervical cancer or endometrial cancer if she is having a endometrial tumor which is presenting as a glandular cells on pap smear. Now, if the woman is having endometrial cells, that was a glandular cells, but now if she's having an endometrial cells, definitely you have to evaluate. It is said in perimenopause, if there is an endometrial cells, 4% chance she may be having hyperplasia and 2% chance she may be having malignancy. In postmenopause, the hyperplasia rises from 13% from 4% and 10% she may be having cancer endometrial. And if there is abnormal endometrial cells, if your cytopathologist say, then there is 25% chances she may be having a occult malignancy in the endometrium. So you have to investigate all these women. The commonest cause of postmenopausal bleeding in our country is carcinoma of cervix. They present as a growth on the cervix, and it is very easy to diagnose. You see a growth, you take a biopsy. But one word of caution, sometimes the endocervical disease where the ectocervix is absolutely normal. So you have to have a suspicion when you see a very bulky cervix, a small uterus, a menopausal woman, always think of either it is a fibroid or a endocervical disease. You need to have a proper sonography and manage accordingly. Endometrial cancer is most common. The most common presentation is postmenopausal bleeding, and the incidence has risen in India. It is the third most common malignancy because of the lifestyle, which I'm not going into this more detail over the causes of endometrial cancer, but 75% endometrial cancers are seen more than the age of 55 years of age. It is usually easily diagnosed because of the symptoms. The risk factor is uh, unopposed estrogen, which is the commonest risk factor, then early nulliparous, late menopause, diabetes, hypertension, obesity. We know this is a classic sign of endometrial cancer. This puts the women in a high risk. So you take a proper history, and if this is a high risk, definitely if she's having postmenopausal bleeding, then you have to investigate thoroughly. These are the women we have to catch them and find out whether they are harboring occult carcinoma or microscopic disease. So, and the other thing is genetic disorder like Lynch syndrome, which is known as hereditary non-polyposis colorectal cancer. If women is having Lynch syndrome, 5% is seen in the colorectal cancer. There is a mutation in DNA mismatch repair gene. 80% risk of developing colon cancer and 40% risk of endometrial cancer. These is only patients where screening is justified, and you have to regularly screen these women with Lynch syndrome. So patients in whom the endometrial cancer should be excluded is women with any women with postmenopausal bleeding, pyometra, endometrial cells in pap smear, intermenstrual bleeding, especially in perimenopausal age, and premenopausal with patient having abnormal uterine bleeding, particularly with a history of anovulation like PCOD or obesity or hypertension. What are the diagnostic tools? I'm not discussing the imaging part because my next speaker is going to talk about it, but the imaging will give you the evaluation of endometrium. Hysteroscopy can be used as a diagnostic and therapeutic. Endometrial biopsy for histopathology, fractional curettage is for histopathology. Endometrial evaluation is done by the transvaginal sonography, hydrosonography, and now we have an international endometrial tumor analysis ETA reporting system, which will be covered by next. So I'm not covering that topic. And what should be the threshold for cutoff for endometrial thickness, whether it is 3 mm or 5 mm. If you take 3 mm, then more of the women will be screened, and more of them will have to be screened, and they will be more false positive and false negative rate. And if when you take 5 mm, you pay probably will rule what miss out some cancer. So what ideally is 4 mm. If it is more than 4 mm thickness in postmenopausal woman, if she's a low risk and very nice thin endometrium and the shares, then the office biopsy can be taken. But if it is high risk, then you need to have a hysteroscopy and biopsy. If it is less than 4 m, if the symptoms are symptom persist, then definitely you go for testing. This is the what we can say a different endometrial thickness for a menopausal woman. In a normal, it is considered 4 mm, and if patient is on tamoxifen, it is considered as a 8 mm. I'll just wind up in few slides. Diagnosis is done by fractional curettage, office, that is endometrial biopsy, and hysteroscopy guided biopsy. This is the endometrial office biopsy procedure where a small probate is there, where you can insert in the uterus and you can take the sample. The efficacy of endometrial biopsy is there's a false rate of 16%. But if there is a small polyp or there is a very small endometrial cancer, but if there is a persistent, then definitely you can go for hysteroscopy and biopsy. Hysteroscopy guided biopsy is very ideal. You can directly see and take a biopsy, but you need to have that setup. Hysteroscopy, the sensitivity is 94%, efficacy is nearly 90%. So these are all different hysteroscopic pictures where you can see difference. So dilatation and gold curettage is a gold standard. It agrees with 90% of the time with the specimen, and hysteroscopy guided DNC is nearly 100% effective. Now, how do you manage this patient with postmenopausal bleeding? If all the women should be investigated, transvaginal investigation is a choice for endometrial evaluation. Less than 4 mm, there is no, the chances of cancer are very low. And if you want to follow this patient, they have to be very reliable. If there is low risk, you can follow them But if she has symptoms persistent, then definitely a biopsy is recommended. If you think your phonologist say it is a polyp or fibroid, you go for hysteroscopy and biopsy. It can be therapeutic and diagnostic at one place. If it is an hematometra, pyometra, definitely go for a DNC rather. And if it is a thick endometrium, then you have to do a DNC or a fractional curettage to rule out biopsy. Any women more than 55 of age, you need to have a biopsy. The guidelines of screening of endometrial cancer is not there, because by screening for endometrial cancer, it is not going to improve the health, or it's not making a woman live longer. So there are certain criteria. There is no mass screening advisable. Pap smear can use as indirect sampling, and the clinical practice is, if it is for more than 4 no bleeding, you have to observe, but abnormal bleeding in a menopause, you have to rule out there. And one word about a hyperplasia: WHO has now classified hyperplasia only in two categories, that is atypical, non-atypical endometrial hyperplasia, which is known as simple hyperplasia, and atypical endometrial hyperplasia, which is known as endometrial intraepithelial neoplasia or well differentiated carcinoma. So you have to investigate. You cannot let these women go. It is like CI in 3, and you have to treat these women. And these are the different guidelines by the British Cancer Society, that routine screening is not recommended. But for Lynch syndrome, the screening should be started from the age of 35. Abnormal vaginal bleeding, you definitely have to investigate. Patient taking on tamoxifen, you have to investigate, and the cutoff is 4 8 And for National Cancer Institute, again with the women with Lynch syndrome, you have to do screening in this women with TVS, and the age is 25. Tamoxifen, definitely you have to do a women under surveillance. This is American female family physician, same guidelines. Any women with abnormal bleeding should be tested, investigated for endometrial cancers. And these are the new thing, which is a PAPSIC test, which has come to detect early endometrial cancer, especially in the high risk women or with Lynch syndrome. And these are Tao breasts, which can be inserted in the cavity, and you take the cells. This is only not for endometrial cancer, but for ovarian and pap smear. Lots of research is going on. There is a microhysteroscopy where with a microscope you can see the
Sorry
cells
to
and
interrupt you, ma'am. Your time is up.
yes, I'm just now shutting down. Last, various take home message: routine screening for endometrial cancer is currently not justified. Was a woman to be educated about the importance of seeking attention if there is a vaginal bleeding occurring. Pap test is not a routine screening test for endometrial cancer, but incident finding of endometrial cells on the pap smear in a postmenopausal woman requires investigation. Screening justified in women with Lynch syndrome, symptomatic tamoxifen, and high-risk women. Evaluation is must in PMB, TVS, and biopsy remains the gold standard. Endometrial carcinoma is seen in all age group, and good prognosis, early diagnosis if properly treated. Thank you very much.
Thank you. Thank you, Anjana. I think over to Dr. Bidan Roy and Dr. Sucheta Dabadkar, who are the chairpersons for this session.
Thank you, sir. At the outset, I thank ICOG for giving me this opportunity, and for the last 2 days, sir, truly it has been an academic feast, and we are getting the pulse of wisdom, the stalwarts of the subject. Coming to the postmenopausal bleeding, as ma'am has almost covered everything, and it has been very nice, complete package for the students to learn. But I'll touch upon 5 facets of the postmenopausal bleeding. Number one is, ma'am has already elaborated. First, it is the history. Second is the gynec examination. And the 3 investigations which are most important as per the triage. Firstly is the transvaginal sonography, then the endometrial biopsy, people endometrial biopsy, and if required, the hysteroscopy. Thank you very much, sir. This is for the students only.
Yes,
Can you
very
please?
nicely summarized, Bidhan sir. Yeah, so after that comprehensive topic, we will now move towards the next topic. And for that, may I invite Dr. Samar Gupte.
The second topic of this session is on role of imaging in endometrial carcinoma, which will be taken by Dr. Samar Gupte, sir. Sir has done his fellowship in gynec-oncology from Tata Memorial Hospital and has trained at UCLH London and is currently practicing as gynecological oncologist in Mumbai. Over to you, sir.
Thank you so much for this opportunity. I thank Dr. Parasnis, Dr. Parag, and the entire team. I'm just going to share my presentation now and I'll start. Uh, yeah, okay. Right. So after that extensive talk and beautiful presentation by Dr. Chauhan Madam, I think mine is going to be very straightforward and simple. So role of imaging in endometrial cancer. So the important thing here to remember for everyone here is that the role is mainly in diagnosis, staging, and planning of treatment. So that is the most important thing that one needs to remember. So there are three questions that we need to answer. Is uterus the only problem? Which means that is the tumor superficial or deep invasion? Is the cervix involved? Or the lymph nodes are involved? That's the second question. So the need for sentinel lymph node evaluation or just debulking larger nodes or systematic lymphadenectomy. And the third question is there distant disease, which is metastatic disease? So that is the three questions you have to answer. Ultrasound is known as the gatekeeper. That is the most important thing that we need to do. Is the first. So usually these are patients who present with postmenopausal bleeding or irregular perimenopausal bleeding. The first thing one does in an ultrasound, as Madam has clearly stated before, it is cheap, quick, high resolution for local tumor, accessible. Only problem is it's operator dependent. So, as we've already discussed, generally ET more than 4 millimeters is where one would do a biopsy for. So, what does one look for in an ultrasound? So, if you look at this picture that I've shown on the right of the screen, and if you can follow my white arrow, this is the endometrial thickness, which is nice and thick, and endometrial hyperplasia. The endometrium is always a little hyperlucent, and there is always a slight endomyometrial halo around it, which is like a hypolucent black area. So, that is how you measure the endometrial thickness. And the moment this lining is disrupted, you know that there's a tumor that's going into the myometrium. So, so transvaginal ultrasound is excellent for diagnosing thickness, for seeing polyps, for seeing small tumors. But, telling about myometrial invasion or distant metastasis or liver metastasis, or even for that matter, for lymph node metastasis, it's not a great evaluation. If you look at this photograph that I've placed in front of you all, right, TVS photograph, if you look at this slide A and for that matter B, these two slides that are there on top, the these arrows show you a thin endometrial stripe right here and right here, in A and B, thin endometrial stripe, and there's a very clear cut nice endomyometrial halo around it. So this is usually a thin ecogenic uniform endometrial with a subendometrial halo, and that is more or less normal. Whereas if you look at diagrams C and D, you will find that there's a lot of chaotic picture out here. There's the endometrium, there's necrosis, there's hemorrhage, and this is typical of what you would see in an endometrial cancer. Uh, since I have to move on, sometimes what is also done is known as a saline infusion sonohysterography, because that is where it improves visualization of focal lesions, especially if there's a big polyp and it is pressing onto the myometrium. You don't know whether it's a tumor that's infiltrating. Sometimes by doing infusing saline and then doing a sonography, that makes it a lot simpler. Remember, it's just an adjunct to the transvaginal ultrasound. You can actually do only a transvaginal ultrasound, and even then, it is more or less effective. Again, it depends upon training and expertise. Um, it's important to remember that ultrasound basically forms the first line of management. But once you've done an ultrasound and you found that there is something there, a DNC or an endometrial biopsy or hysteroscopy is essential. Once that is done, then you come to further imaging. Usually in endometrial cancer today, MRI becomes the standard of care. Now, the question I'm asking here is MRI important in diagnosis? Which means, should you do an MRI before you've done a biopsy to figure out whether there's an endometrial cancer? No, MRI's role comes after you've diagnosed an endometrial cancer. Sometimes, right, if your ultrasound is inconclusive, then you can do an MRI. Sometimes when you know that this patient has a complex uterine anomaly, for example, ultrasound tells you a bicornuate uterus or a large septum, in these are the patients you can do an MRI to figure out, is the endometrium really thick? What is the situation? Where is the cornu? So those are some of those situations where you would do an MRI first only rather than doing a biopsy before. Right? So MRI, again, I'll just come to certain basic images that you need that for students to understand. So when you look at an MRI, again, it's important to understand that, if you look at the figure on the left here, it's a nice big uterus, beautiful that you can see here. The endometrium is always slightly more hyper intense. it is always a little brighter. The endomyometrial halo or the endomyometrial junctional zone is slightly less hypo-intense, and the cervix is always hypo-intense. So these are some of the things that we as clinicians should remember, so that it's important for us that when we are looking at an MRI, we can actually differentiate what is happening. Another thing that we need to understand is the age variation. If you again look at the picture on the left, you can see a nice big uterus, which is in a 30-year-old lady, a good, nice endometrial stripe inside. The junctional zone is intact, and the myometrium is beautifully seen, and a hypo intense cervix is also nicely seen. Same thing if you look on the right side of the picture and you follow my arrow, which is coming in. This is the uterus here. You really can't see. You really can't see anything properly simply because in older women, it's very difficult to differentiate between them. And I'll come to how the radiologists actually come around to differentiate it more clearly. So as I said, it's the gold standard for local staging, assesses myometrial depth, cervical stromal invasion, and tumor size. And your accuracy is almost 95% for local staging. So the key MRI sequences that you really need to remember is the T2 weighted images. I know, I'm sure people have heard of that. The T2 weighted images talks about anatomy and junctional zone. For example, look at this picture A, right top of the left side top of your screen. You can clearly see a nice big endometrial mass and the uterus around it. Then you have something known as a T1 weighted image, which is fat suppressed and usually with contrast. So if you look at the B image, that's what it is. The contrast is now opacified the entire myometrium and the tumor is inside. The tumor is usually absorbs less of the contrast. So therefore it becomes a little hypolucent or hypo-intense. The most important image today that most radiologists will talk about is the DWI, which is the diffusion weighted images. So what happens in diffusion weighted images is that the cancer cells are very tightly packed. So water does not permeate between them, and therefore the tumors light up. For example, if you look at C, or if you look, this is what you can see. The tumor kind of lights up very brightly here. And you can easily make out endomyometrial invasion. For example, if you look at a T2 weighted image on top, number A, you can see there's a nice tumor, but you can't make out invasion very clearly. This image at C clearly shows you the invasion, myometrial invasion. So they talk about what is known as the money sequence, which means if you do a T2 weighted image along with a DWI and superimpose them on each other, you're going to get the image D, which will give you a much clearer idea about what the tumor is doing. Right. So same thing, some more images for myometrial invasion. This is really important because we know that greater the myometrial invasion, greater is the propensity for lymph node metastasis. And this changes your surgical plan, whether you want to do sentinel lymph node, whether you want to do a systematic lymphadenectomy, whether you want to go minimal access, whether you want to go open surgery. And that is something which other speakers will discuss with you at a later point of time. The next most important thing is cervical stromal invasion. This is again very, very important. This is where MRI really is beautiful here. If there is a disruption of the cervical stromal to stroma on a T2 weighted anatomical image, then it's very clear. For example, if you look at this A left top image, you can see a nice big tumor, the uterus here, the cervix here, and you can see that it's sitting right there in the cervix involvement, right? So again, if you look at it from a DWI image, which is D and E, you can make out what is happening very clearly in that also. So typically, again, I'll just repeat by telling you that the endometrium is hyper intense. Usually, the tumor is slightly less intense than that. It is intermediate intensity. The cervix is always hypo intense. If you look at figure A, it's black. And the myometrium is also less intense than the tumor. So, this is how you differentiate between the three and come to know. Just for your benefit, the images that are there in D, F, E, and F right at the other end, the E, F, G images, these are actually T1 weighted fat suppressed contrast images. Now, the reason they put three pictures here, that is in E, F, and G, is simply because they are done at different times. So E is an early phase image, which is done within 30 to 40 seconds. F is it's called as the equilibrium image, which is done in about 2.5 minutes. And G is the delayed image, which is done in 4 to 5 minutes. So if you look at these images, they all opacify tumors in a different way, opacify the tumor, the myometrium, and it becomes very clear for a radiologist whether cervix is involved, myometrium is involved, serosa is involved, whether the parametrium is involved. So this is how they look at these pictures. Lymph node evaluation, that's something which is more extremely important. Now the criteria here is if you have a lymph node which is more than 10 millimeters in size, it is round and there's loss of hilum architecture on an image like CT, MRI, then they are likely to be metastatic, which effectively means that if you've got a lymph node smaller than 10 millimeters, it is along the axis of a blood vessel and is oval in shape, and you can see the hilum, then they are not involved lymph nodes. So this is how we, kind of differentiate on MRI and CT scan. Right. So again, here, if you look at this top two images, that is image A and image B, you're going to see these two big round structures at the side, which I'm trying to show with my arrow here, two big structures. These are enlarged bilateral internal iliac lymph nodes, which are more than 3 centimeters. If you look at the architecture inside them, it is heterogeneous, non-homogeneous, and you cannot see a hilum in them. And these are most likely metastatic lymph nodes. Similarly, if you look at the picture below, this is my patient, actually a 78-year-old lady who has this round structure that is shown here. That shows a small external iliac node, which is again more than 10 millimeters, but it's round, it is homogeneous, and the hilum can be clearly seen. And this, when I removed, was actually non-metastatic. So when a radiologist sees the image C and D, they are going to say that enlarged nodes are present, but they are reactive because he or she knows that they are unlikely to be involved and metastatic. So this is how they differentiate, and then this is how they tell us what they think it is. When you come to CT scan, it's important to remember that CT scan has a better multiplanar spatial resolution. Therefore, distant metastases are better seen, right? More often than not, this is what you would see. Again, I'm going to show you these images a little more in detail so you'll understand what I'm seeing. A and B on your left, they are CT abdo-pelvis with contrast. You can clearly see a nice big endometrial tumor inside here, but you can't make out much more whether it's invading the myometrium, what it is doing. C and D are MRI images of the same tumor. C is a T2 weighted image. D is a diffusion weighted image. In this, you can see that same tumor has invaded the myometrium very clearly. So that's how your MRI is better than the CT. But E and F are CT abdo-pelvis thorax with contrast, and you can see metastatic pulmonary nodules in E, and you can see large para-aortic nodes next to the blood vessels. So this is where your CT and MR are different. Your CT scan is going to tell you more about distant metastasis. More often than not, if my biopsy tells me that it's a high risk, high grade tumor like a uterine papillary serous or an endometrioid adenocarcinoma grade 3, or it is a clear cell carcinoma, I will do a CT scan. I will not then waste my time doing an MRI. PET scan detects metabolically active lymph nodes. It is for seroperitoneal disease. Detection rates at 12% for small lesions. So again, smaller the lesion, even PET scan may not be active. But for lesions more than 10 millimeters, PET scan is excellent. Again, PET scan I would do for high risk histology for large tumors because I know there's a chance for metastatic spread. And the best use of a PET scan is for evaluation of recurrence. So 3 years later, if a patient comes back to me with some bleeding and there's a recurrence, then PET scan is excellent for that. So quickly, I know I have to end my talk, but if you look at some special situations, remember high risk histologies, I would rather do a CT with a PET. Fertility sparing candidates, MRI is absolutely essential. After your treatment of endometrial cancer and you're doing surveillance and calling them for a follow-up, imaging can be done in the form of an ultrasound along with clinical evaluation. But for high risk histologies, I would still recommend doing a CT scan on a routine basis, at least once in 6 months or once a year. Another use for imaging in endometrial cancer is sentinel lymph node mapping, which I think one of my colleagues will talk about a little later. And the next important time is imaging in radiation planning. So for IMRT or IGRT planning, imaging is absolutely important. The radiotherapists use that excellently. So simplified algorithm is do a transvaginal ultrasound, thick endometrium, do a biopsy, low grade tumor, do an MRI, high grade tumor, do a CT or a PET scan. And if there's a recurrence, do a PET scan. So at the end, we have answered the three questions that we had talked about. Is the uterus the only problem? Then you can check with a transvaginal scan and an MRI. If the lymph nodes are involved or not, you need to do a CT scan or a PET scan. And if there's distant disease, you're talking about CT scan and PET scan again. So I think I'll end my talk with this and thank you for a patient hearing.
Yeah, Dr. Samar, it has been excellent presentation with absolute clarity. That's I hope the students will have no doubt about how to approach the imaging part of in case of endometrial cancer. A lot of
Thank you.
questions
Thank
have
you.
come up regarding the PET scan. Would you like to, for the sake of the students' benefit, would you like
Yeah,
to
yeah,
add
I'll
something
just,
more about PET CT scan?
That was
A
a
lot of
very
questions regarding that. Two, three questions.
yes, one second. Now, what have they asked?
They have asked basically a wider role of the PET-CT scan.
Yes, so the
So
main question, sir, here
if
is
you
what is
can,
the role of PET scan in endometrial cancer? So again, let me start from the beginning. PET scan is not for diagnosis. When a patient is diagnosed with an endometrial cancer, the way we follow it is if it's a low grade histology, it is very unlikely to be metastatic. And then obviously I would not recommend a PET scan. But if it's a high risk histology, like a clear cell carcinoma or uterine papillary serous or a carcinosarcoma for that matter, then those are the patients who are likely to have a metastatic disease. In those patients, I would rather first do a CT abdo-pelvis with contrast. Now, in that, if I find there is some amount of omental thickening, those are the patients that I'm 100% going to do a PET scan for, because I want to rule out liver, lung mets, and seroperitoneal disease, which is better seen on PET scan. So one has to be selective. At the same time, we also understand that in today's day and age, a lot of people are doing PET scans left, right, and center, but that is not ideal. So a PET scan has to be used very sparingly. The second indication, which is better actually for a PET scan, is in recurrent situations. So if a patient comes to me with vaginal bleeding, or after 4 years of being treated and she was normal all along, and on evaluation you don't find anything, but there is slight bit of irregularity at the vagina, nothing is very obvious. Those are the patients in whom I would do a PET scan, especially if she had been originally treated for a high risk histology. So that those are the broad indications for a PET scan, I would say.
absolutely. And for the benefit of the student, when the SUV max is maximum, then it has also got a prognostic significance also. So in high
Agreed, sir.
risk,
Agreed.
yeah. So in high risk cases and high risk these endometrial cancers, the capacity scan, the SUV max is also high, and the prognosis is also there. Now a little bit of, because the AI has come, artificial intelligence has come a lot of many things in gynae oncology, more so in early ovarian cancer. Your endometrial, in case of endometrial cancer, what is the latest of artificial intelligence?
I think the use of artificial intelligence, sir, is mainly in diagnosing, and it's in radiology. So I think eventually it will be the radiologist who are going to answer that question. But yeah, I mean, you're right. Artificial intelligence with machine learning is going to be the new thing, where they'll be able to superimpose your PET, your MRI, your CT, give you a more coordinated answer. I think maybe something like that.
Yeah, absolutely, sir. Absolutely right. For the benefit of the student, again, it is the early ovarian cancer detection that artificial intelligence has got some ability by radiomimetics and all these things. But I don't know about endometrial cancer per se. Thank you very much. Thank you for this
Thank
nice.
you.
Thank you, sir. The third topic of this section is on molecular classification of endometrial cancer, which will be taken by Dr. Shalini Rajaram, ma'am. Ma'am is Director Professor VMMC and Safdarjung Hospital, Delhi, and Professor Program Coordinator for MCH Gynecologic Oncology at AIMS Rishikesh. Over to you, ma'am.
Yeah, thank you. My slides are with the organizers because
Yes,
I could
ma'am.
not project them. And at the outset, let me thank Dr. Harshad for the invitation and ICOG. And I hope to make things simpler after this talk, after we had the two excellent talks by the two speakers. So why, no, just keep it on that first slide, please. There's going to be a problem, yeah. So why molecular classification of endometrial cancer? Because I think now everything has become personalized medicine. It has, in fact, complicated the treatment of endometrial cancer because there are so many changes at the molecular level. But it is important not only for prognosis, it is also important for selecting adjuvant treatment. It's also important for de-escalating treatment or enhancing or increasing the treatment. So let's understand what the molecular classification is all about. Next slide. Yeah, so the learning objectives of this lecture would be to understand the various molecular subtypes of endometrial cancer that are used today. There are a number of molecular classifications, but today a few are used, maybe 4 or 5. We'll talk about that. And it first started off with the endometrial cancer being genotyped by the Cancer Genome Atlas, which was a very complicated system because it considered next generation sequencing, and it used fresh tumor tissue. Then we went on to the PROMIS classification, PROMIS classifier, and that also talks about sequentially doing some molecular types. But I think it's easier now because we have some IHC markers and only maybe one of them would be an NGS sequencing. So we'll look at these in the subsequent slides. So we'll learn how these molecular subtypes have changed the risk categorization and the need for adjuvant treatment. Which patients require adjuvant treatment, which patient we can omit adjuvant treatment based on molecular subtypes. And the FIGO staging has been changed based on the molecular subtypes, which was first put forth by ESGO in 2021. But that will be covered by Dr. Rohit, so I won't get much into the FIGO staging. And to understand that why molecular types are required, especially for targeted therapy, because today, suppose there's a recurrence or there's metastasis, or even upfront treatment, which are the molecular subtypes which are going to respond to immunotherapy. Next slide, please. So the landscape of molecular next. So we start next, please. Yeah. So it started in 2021 with the incorporation of molecular markers for risk stratification and management after the TCGA classification, which came about sometime in 2015. Next. You can keep doing next till the last year. So FIGO incorporated molecular staging, molecular markers into their staging in 2023. Now again, ESGO has again reincorporated the FIGO guidelines into molecular staging in 2025. And POTEC 4A was the first trial which incorporated molecular markers in high intermediate risk cancers. And these results were recently presented in ASTRO-ASCO in 2025. So we have many more markers today to navigate rather than the original 3 markers. And a number of clinical trials are there using immune checkpoint inhibitors. In fact, it's the MSD deficient tumors or the MMR deficient tumors are the ones which respond really well to immunotherapy. And there are various treatments which we'll talk about later, a little later. Next slide, please. Next slide. Yeah. So one of the major advances in endometrial cancer management is the ability to molecularly segregate and classify these carcinomas, and the most impactful of which was the Cancer Genome Atlas classification. But as I said, that was much more cumbersome than the presently used classification system using immunohistochemistry. So we had 4 categories. That was the pole, ultra mutated cancers, which are good prognosis cancers. Microsatellite instability is given, the report is given when you do a sequencing. Otherwise, it's MMR deficient, MMR proficient. Copy number alteration high. These tumors behave like ovarian cancers with T53 mutations or P53 mutations. And the other, the last group is the copy number low, which actually constitutes 50% of the tumors. Next. Now we can use 3 immunohistochemical markers, that is P53, MSH6 and PMS2 initially, and 1 molecular test that is for the pole mutations. And the pole mutations comprise about 5 to 7% of all endometrial cancers, but these are the best prognostic markers. The MMRD is 25 to 30%, which are intermediate risk cancers. P53 abnormal are the most high risk, and no specific molecular abnormality is about 50% of the endometrial cancers. Next slide. So the promised classification, they said you first do the MMR proteins by IHC, and then if they are positive, then you can start the sequential algorithm for diagnosis of Lynch syndrome. And then if that was intact, you go on to do the pole mutations, and if the pole mutations were intact, you went on to do P53, so on and so forth. But basically, you need to do all 3 of them to actually classify the tumors as molecularly classified. Next slide, please. So when you do pole mutations, they say you need to do 11 pathogenic mutations. So the labs might come and tell you that, yes, we do pole mutations in 2 or 3, but what they recommend is all the 11 types. And MMR, we normally say loss of expression. Normally, when you talk about IHC, you talk about overexpressed cells like P53. But in MMR, it is loss of expression of these proteins, that is MLH1, PMS2, MSH2, MSH6. And if the MLH1 there's a loss of expression, they do a hypermethylation of MLH1, because if it is hypermethylated, it means it is a sporadic cancer. If it is not methylated, it means it's a Lynch syndrome, and you have to start testing for Lynch syndrome. Lynch syndrome is like 5 to 7% of all endometrial cancers, whereas MMRD may be positive in about 30% of endometrial cancers, 25 to 30. Then P53 is again an immunohistochemistry marker, and absence of MMRD or P53 is called NSMP. Next slide. Now, NSMP has again been further categorized today because NSMP formed that intermediate category where the risk was an intermediate risk. So now NSMP are classified into estrogen receptor positive and estrogen receptor negative tumors. The estrogen receptor positivity, you say, when there's more than 10% of the tumor cells have estrogen receptors. And when they're NSMP and low grade and the estrogen receptor positive, they are low risk tumors. Whereas if they are high grade tumors and they are estrogen receptor negative, they become higher risk. They may require adjuvant treatment. So at one end you have pole, the other end you have P53, and in the center you have the MMRD and NSMP high and low based on the estrogen receptor status. Next slide, please. So this is the one which we've been seeing over the years, showing you the prognosis of these tumors with pole mutated tumors. Even though it's called ultra mutated, they're the best tumors in terms of prognosis. So you can de-escalate treatment, even if they are stage 3, stage 4. Though of course we give the management as per stage 3, stage 4, but they do well. So the green would be the MSI hypermutated. So you can see the green and the yellow lines going almost hand in hand. But now probably with the NSMP being further categorized, we will have more curves for prognosis. And then, of course, the P53 is the serous ovarian-like tumors, which are much more aggressive. Next slide. So this is the new categorization or new risk classification, which is given in 2025 by ESGO-ESTRO. It'll be very difficult to remember all this. So once Rohit talks about all the staging, this is kept as a ready reckoner. So the green ones means they are low risk. They don't require any adjuvant treatment. So stage 1 or stage 2, if they are pole mutated, they are low risk. Even if they have LVSI or have deep myometrial invasion or they have a cervical invasion, if they are pole mutated, they are low risk tumors. Then the yellow is the intermediate risk. The gray is uncertain risk classification. The red, you can't make out the difference between red and orange here, but the red is the high risk whenever there's P53 abnormality, even if it is confined to the endometrium with no invasion. Now it comes under the high risk category and they require some form of adjuvant treatment. And the orange is the high intermediate risk. So this is that category which requires, some of them require classification, require adjuvant treatment. Sorry. Next slide, please. Yeah, so if you look at stage 2, you have the next slide. Yeah. So if you see the stage 1 becomes molecular classification pole mutated, which is because of pole mutation positive, even if they are involving the cervix or deep myometrial invasion or LVSI, it is still stage 1A molecularly classified. And if P53 is abnormal, they become stage 2CM P53 abnormal. And these are for uterine confined cancers. Next slide. So what is the best time to do molecular markers? The best time is when at the initial DNC, because this is when the tissue is very well preserved and suited for molecular testing. Post hysterectomy, the endometrial tissue may be lost because it's quite fragile and there may be poor handling. So the best time to do it is initially. But you can repeat it later if you think the tissue was very scanty initially, you have results equivocal, or there's a different tumor type found on the final histopathology. And immunohistochemistry is best for MMR status and P53, while pole needs sequencing, and recommendation is to do all 11 pathogenic variants. Next slide, please. So now there's a new, we have multiple classifiers. You can't be happy if you just have one. You can get sometimes P53 abnormal, pole abnormal. You can get MMRD plus P53 abnormal, various permutations and combinations. But P53 abnormal with a pole mutation, P53 is a passenger mutation. So it happens during the pole mutation. So it is still considered as pole mutation and it's a good prognosis tumor. MMRD, likewise, if you have P53 positive with MMRD, it's again a passenger mutation occurring during the mutagenesis or tumorigenesis. So still it is considered MMRD. Pole mutation with MMRD, earlier they said we did not know what is the risk, but today they say consider as pole mutated, but of course the evidence is not enough. We'll have to wait for more evidence. And if all three are positive, pole, MMRD and P53, they say you still consider it as pole mutated. So we'll just have to see for further evidence because this is all level 4 evidence. Next slide. This I think Dr. Rohit is going to speak about more. So you can divide them into various categories, and depending upon the categories, they require no adjuvant treatment or vaginal brachytherapy, or you may consider no adjuvant if they are young patients. They're high risk patients. Of course, they require EBRT and chemotherapy. If they're P53 abnormal, they definitely need chemotherapy. Yeah, next. So basically, next, just press, yeah. Basically, all this came, the molecular classification was used in POTEC 3. And in POTEC 3, they found that P53 abnormal tumors definitely required some form of chemotherapy. They did better. And patients with MMRD tumors did not respond to chemotherapy. So there's no point in giving them chemotherapy. Next. So POTEC 4A was the first trial, which actually the results have not yet come out fully. It's not yet published, but they used in high 1B tumors, that is high intermediate risk tumors. Next. Yeah, so they used in one arm only vaginal brachytherapy, and the other arm, depending upon the favorable category, they used either vaginal brachytherapy, or they did not give any adjuvant treatment, or they used EBRT. EBRT. Next, this is for high intermediate risk. So this slides you may have seen earlier. My time is running out. So you have three groups: favorable, intermediate, unfavorable, depending upon the molecular profile. Next. Then you can go to the last slide. So this actually showed that patients who received next. Yeah. Patients, you could omit adjuvant treatment in 46%, 40% receive VBT, and 14% escalation of treatment. Whereas in the VBT arm, 100% receive VBT. So this is basically the high intermediate risk group to select who requires adjuvant treatment. Next. If I'm getting late, I can wind up. I can go to the summary slide. Yeah. So the rainbow trial, next slide. Next. So the rainbow trial actually, no, just go to the rainbow. Yeah. So basically in these, it's a trial which is still ongoing. So basically based on their molecular profile, they can be given PARP inhibitors or immunotherapy or hormone therapy, or you can give no adjuvant treatment, or you can de-escalate. Next. Yeah, you can just skip these. These are some examples. We can just go to the final slide of summary. Yeah. So just come back to that slide. So basically, you have a number of molecular markers. There's a huge landscape of molecular markers, but what we use today are the MMR proteins, the P53, the ER/PR is important today, and earlier also it was important, and P53. These are the other markers which probably will come into prominence at a later stage. Next. 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 Yeah. So basically, HER2 positive cancers are seen in HER2 is done in patients with P53 positive tumors, and they can be given Herceptin just like in breast cancer. But this is again an ongoing trial. People with HER2 positive endometrial cancers can be given targeted therapy like Herceptin or trastuzumab. So the summary is excellent prognosis for POL ultramutated, intermediate prognosis for MMR deficient MSI high, investigate for Lynch syndrome. These are really responsive to immunotherapy and radiation. P53 abnormal, they respond better to chemotherapy. And no specific molecular profile. Now we have two subcategories, which are estrogen receptor positive and estrogen receptor negative. And of course, they will, I'm sure, in the next few years come out with other molecular markers for this category. Next. So the future direction is integrating molecular diagnostics into routine care, which we've already started doing. Personalized therapy based on biomarker-driven decision-making like immunotherapy, which is again, people have started using it. And a paradigm shift from histopathology-based to molecular-guided treatment. Yeah, thank you. Thank you so much. And I'm sorry, I always overstep. I'm sorry for the...
Ma'am, it has been an excellent talk, and it's just such a complicated thing that you have dealt with with such clarity. Amazing, ma'am. Regards to you, ma'am. Just one thing, ma'am, your opinion, because I feel if you don't include the molecular diagnosis, it is an ethical issue nowadays. So,
Yeah.
as you have rightly said, that the pre-op bulk of tissue that you offer for the endometrial biopsy should be good enough to do the IHC part also. So
Yes.
this is what I feel, because as we know that there is a lot of discrepancy between the pathologies themselves in case of differentiated tumors, well differentiated, moderate differentiated, poorly differentiated. Now in case of you find a poorly differentiated cancer or a high grade cancer, it is imperative that we should go for molecular diagnosis. And it is unethical if we don't go so, because the whole root of study and the everything changes once the molecular diagnosis is at hand. What is your take on that, ma'am?
Yeah. It is necessary for even endometrioid cancers, which are high grade, maybe grade 2, grade 3, high grade endometrioid also, and definitely for the others, especially for uterine confined cancers. And it is important today to incorporate molecular markers, at least 3 or 4 molecular markers for management.
True, ma'am. And rightly, ma'am, in the earlier days, ma'am, ER/PR is more of the breast cancer. Now, ER has been integrated into endometrial cancer also. As you have said, serous cancer, it will be already a metastatic disease. The serous carcinoma, it will already be a metastatic disease by the time we come to know. As Dr. Samar has also said, that the about of integration of the PET-CT in those cases. Thank you, ma'am.
Thank you. Yeah, I'll answer any questions in the question box. I can answer it there. Thank
Yes,
you.
ma'am. Suchita, ma'am, any comment, ma'am?
No,
Harshad,
Suchita,
sir.
man, I think Dr. Suchita had just to leave because she had an emergency. So I think Likita, we can continue with the next.
Yes, sir. Thank you, Dr. Shalini, ma'am. The fourth topic of this session is on newer FIGO classification of endometrial carcinoma. This session will be taken by Dr. Rohit Ranade, sir. Sir is Senior Consultant and Clinical Lead Gynecological Oncology at Narayana Health City, Bangalore. Over to you, sir.
Thank you. Thank you. At the outset, I must thank Dr. Harshad, sir, for giving me this very, very theoretical talk. Thank you for your talk. It is just because of this talk that I have finally managed to read the classification on endometrial cancer. One disclaimer, though I will be presenting the talk, are my slides visible?
Yes.
Yeah.
Yes.
So one disclaimer, as compared to the other stagings, like ovarian cancer staging had a change, cervical cancer staging had a change. This staging has made it from confusing to much more confusing. That's what I was just discussing with Samar in the afternoon. And we still have to actually find out the actual clinical utility of this staging. But I think it's still early days. This staging has just come in 2023. I'm sure a lot of thought process has gone in the FIGO committee regarding why this staging has been changed. But this is one of the few radical changes which have been done in the staging. And now we know that which was the disease which was considered to be a low risk is now more or less high risk. Again, the so-called high risk disease has also been subdivided. So over the course of next 15 minutes, we will just look at what these changes are and what clinical implications these changes could have. Dr. Shalini has already given a fantastic talk on molecular classification, which has made my life a little easy. So I will not go much more into the details of the molecular classification, and I will stick mainly to the staging. So the FIGO staging first was put forward in 1998, where it was subdivided into the 4 classes that we know. And then in 2009, it was again updated, where there were few certain changes which were made. Primarily, the stage 2 was changed, and then again 1C was removed, and it was only into 1A and 1B. Now, this is what is the staging of the FIGO 2003 classification. It has, what change has been done is it has again now been divided into A, B, and C division, like what was in the early 1988 classification. And we look at why it was changed and what are the different changes that have been made. So what is the need basically for a new staging system? We know that the last staging update was in 2009. It's nearly been close to around more than 15 years that the staging was not changed. So that was the reason why the FIGO committee decided to change it. A major change has been, we now know that molecular profiling is the way for future. No two cancers behave as same. So it's molecular profiling which has definitely come into the clinical practice, and that's the reason why the staging has been changed. Also, we know that in the last decade there have been major advances in terms of management, be in terms of surgery, be in terms of immunotherapy and other treatments that have come into the practice. Now, it's basically a considerable new information which sorts of better defines the pathology and especially the molecular findings as they relate to the type of endometrial cancer. We have newer treatments. We have a lot of new clinical trials and prognostic survival data, which will correlate with the surgical and pathological system. So this is mainly an effort to separate the prognostic groups and the staging system. Now, the prognostic risks are basically defined as estimated 5-year recurrence risk of recurrence. In the low risk group is less than 8%, we know. Intermediate risk group is between 8 to 14. The high intermediate risk group is between 15 to 24, and the high risk group is more than 25%. That is something that we know. Now, what are the changes which are there in the stage 1? So in stage 1, if you look at the old stage 1A, these were all tumors which were confined to the endometrium, as well as somebody who had more than 50% myometrial invasion. Now that has been split into 3 stages, that is 1A1, 1A2, and 1A3. The 1A1 is essentially the non-aggressive types. They are all especially when the tumor is diagnosed in the polyp or in the endometrium, where there is no myometrial invasion, because we know that now MRIs are quite sensitive and we can pick up even subtle amount of myometrial invasion. So that is what is changed. Again, 1A2, these essentially are all non-aggressive types where the myometrial invasion is less than 50% and there is no or focal LVSI. When no LVSI, we mean that there is no, we do not see the lymphovascular invasion in any vessel. Focal LVSI is when there is less than 5 blood vessels where there is a lymphovascular space invasion, and substantial LVSI is when there are more than 5 blood vessels which are involved. Now, 1A3 is the non-aggressive limited to the uterus and ovary. This is changed from what it was in the previous classification. Now, in the previous classification, if the ovary was involved, they would straight be taken into stage 3. So that is why this is a big change which is there. So these tumors are no longer classified into stage 3. They are essentially into stage 1A3. That is, so these are basically, in a broad terms, these are tumors which have superficial or myometrial invasion less than 50%. There are no additional METs and there is no substantial or extensive LVSI. And this is whenever there is a unilateral ovarian tumor involvement to one ovary without capsule invasion or rupture, they are classified into the new 1A types. Now, the old stage 1B was when there was more than 50% myometrial invasion. The new stage 1B includes non-aggressive tumors. This is again divided into 1B and 1C. So 1B is now all the non-aggressive cancers. They have no focal LVSI, no or focal LVSI, and more than or equal to 50% myometrial invasion. The new type is the 1C, where it is known as the aggressive, where it is an aggressive polyp or endometrium. Now, in this is very important because more than 40% of higher grade tumors are in this category. They may have an occult lymph nodes or peritoneal involvement, and hence they are actually stage 3 disease. So that is why this stage 1C has been newly formed. Now, stage 2, we all know that in this classification, again, it is divided into the stage 2A, which is the non-aggressive tumors. They may have LVSI, either no LVSI or focal LVSI. And when LVSI is present, it is stage 2B. And all aggressive cancers. Now, by aggressive cancers, I mean all grade 3 endometrial cancers, all serous cancers, all clear cell cancers, all mesonephric-like carcinomas, all mucinous, undifferentiated, or carcinosarcoma. So there is a lot of importance which is given to histology. So any cancer which was like if a lady has a high grade serous cancer, no myometrial invasion, no LVSI, but still it would be stage 2C as per the newer classification, because this would come in the aggressive type. So here, when somebody has an aggressive histology, the myometrial invasion doesn't matter. So that is why we will have more and more patients in the stage 2 subtype with the newer classification. Now, stage 3 is basically involvement of adnexa, vagina, or nodes. So again, that is divided into stage 3A, stage 3B, and stage 3C. Stage 3A is essentially when either the ovary and the fallopian tube is involved, and this is except 1A3. So when there is a ovarian surface involvement or the fallopian tube is involved, then it is 3A1. 3A2 is when the uterine subserosa or the serosa, when there is a tumor in the uterus and it is going up till the serosa, it is classified as a uterine 3A2 essentially. 3B1 is when vagina or parametrium is involved. 3B2 is when pelvic peritoneum is involved. So this was a sort of fallacy in the previous classification that peritoneal involvement was taken as stage 4, there was no difference whether it is a pelvic peritoneum or peritoneum outside the brim, outside the pelvic brim. But now we know that suppose there is a somebody has a tumor in the uterus and there is a small deposit in the uterosacral area which is positive. So it is not stage 4. The patient is classified as 3B2 because they behave differently than from stage 4 cancers. Again, stage 3C is the nodal involvement, which was similar to the previously, but now there is a subdivision between micromets and macromets. 3C1 when somebody has micromets in the pelvic area, 3C2, 3C12 is when there are macromets, and 3C2, C21 is micromets in the paraortic region, and 3C2 is macromets in the paraortic nodes. Obviously, it is only taken up to the renal vein. Something above the renal vein is considered as metastatic disease. Stage 4 is again known as metastatic disease when the stage 4A is when the bladder mucosa or the intestine or the bowel mucosa is involved. Now, stage 4B is disease when the abdominal or the peritoneal mets are beyond the pelvis. Say tomorrow there is a patient with a uterine mass who has a omental disease. That is a stage 4 as the newer classification as well. Also, any distant mets, including extra or intra-abdominal node above the renal vessels or lung, liver, brain, or any systematic mets, inguinal nodes is also stage 4C as per the newer classification. Now, I will not go into more into molecular features. They are mainly used to classify endometrial cancer as low risk or high risk, especially only in stage 1 and stage 2. And they estimate the risk of recurrence, and we can also know the survival. Basically, Dr. Shalini has already talked about pole gene. I will not go into the details of this. Uh, this thing, we all need to know that P53 mutated tumors are all aggressive cancers. They have highly unfavorable prognosis. Most are serous. 25% may be endometrioid or carcinosarcomas. And this is so as per the endometrial cancer has been classified into 4 groups as per the TCGA approach. It is either pole mutated, MMRD mutated, P53 mutated, or the no significant type, which is something which is important. So it's it's important for us in all patients to do molecular profiling, because molecular profiling will help in the prognosis. It will help in determining the adjuvant treatment, as well as it will help us to determine the stage of the patient. So with this, I would like to stop. And also one more thing which I wanted to add is, it is also important to know which is the driver mutation. There will be some patients who will have a pole mutation as well as a P53 mutation. Most of the times it is the pole mutation which is the driver mutation. So in that situation, the P53 mutation can be ignored. It is mainly the pole which is the main driver mutation which is important. So that is something also which we have to know. So with that, I can stop. If there are any questions, I would be more than happy to answer.
Thank you, Dr. Rohit. It has been a very nice presentation. And as you have said that you have read it because of the presentation, one of us has read it because of your presentation only. It is a very complicated. We don't learn it by heart. We just go through it when we met with a situation like that.
I just wanted to remind Rohit that maybe they will be not students may not be asked for what surgery is being performed, but they will surely be asked about the staging in their exam. So that was the reason why they
But
said.
sir, it cannot come as a question because it is so long, sir. Earlier,
Yeah.
endometrial cancer used to be a question in the postgraduate with 10 marks in DNV also, but it will not come nowadays. But one theoretical question I'm just asking for the
Yeah,
sake of the
please.
student. Please clarify about stage 1A3 and stage 3A1, the involvement of the ovary, and
Yeah.
a little bit about micrometastasis and macrometastasis. I think that will
Yeah.
be a good thing for the students.
Yeah. So basically, see, when there is a tumor in the uterus, which is sort of, there are no LVSI, and the myometrial invasion is less than 50%, but there is a synchronous involvement of a ovary where there is an ovarian deposit, but it is not breaching the capsule. It is 1A3. Hello?
Yes.
Yes, yes.
Yeah. Uh, but in a situation where there is a sort of involvement of the ovarian capsule, or there is a tubal involvement, fallopian tube involvement, in addition to the tumor in the uterus, then it is 3A1.
True.
I think it
And
is a
micro
very
and macro.
Rohit,
Micro is micromets is they have basically just subdivided into again micromets is again 3C1 part and 3C1 is pelvic and again divided into pelvic micromets versus pelvic macromets. Now, as far as the adjuvant treatment is concerned, that doesn't make a difference because even now, even if there are ITCs as per the Sentinel node criteria, even ITCs are considered as mets. So irrespective of whether it is micromets or macromets,
Isolated
the
tumor cells. For the students,
yeah.
isolated tumor cells.
So sorry, ITCs means I'm so sorry for isolated tumor cells. So whether it is isolated tumor cells, whether it is micromets or macromets, it is all metastasis. So the patient has to be treated according to that. I mean a combination of chemo and RT.
Thank you so much. Thank you so much.
thank you. I think Rohit, that was an excellent talk. Actually, as you rightly have put it, it's a very complex. A simple topic of staging has been made very complex by the authority by FIGO, and then for students, they are now. There was a time when people were worried about ovarian cancer in the exams, but now they're not. They're worried more about endometrial cancer staging, and that is
Right.
why this topic. Thank you for an
And
excellent
what has
talk.
happened is, sir, for adjuvant treatment, if you add molecular to it, it becomes much more confusing.
Yes. Thank you. Thank
Okay,
you,
thank you.
Rohit.
Thank you. Thank you.
Likita, over to you.
Yes, sir. Thank you, Dr. Rohit Ranade, sir. This concludes our session 1. And thanks to the chairpersons of session 1, Dr. Suchita Dabadkar, ma'am,
Dr. Bidan Roy.
and Bidwan Roy, sir. Starting with session 2. The first topic of this session is on surgery for endometrial cancer by Dr. Yogesh Kulkarni, sir. Sir is head of gynec onco and robotic surgeon at Kokilaben Dhirubhai Ambani Hospital, Mumbai. Over to you, sir.
Can you just show the slide for Dr. Kavita Singh also? I want to welcome Dr. Kavita Singh. Can you just show her slide, please? Yeah. Yeah, the slide before this. Yeah, I think we must welcome Dr. Kavita Singh. She is the dean of the GMC Bhopal and fellow gynae oncologist. So I welcome Dr. Kavita Singh to this session to chair the session. If you can you give few words before I think you are quite
Yeah,
tight on your times. That's what
yeah,
I came to know. So
yeah. Okay. Thank you, Dr. Harshad, for remembering me and inviting me to uh, be part of this session. Such a very important session on surgery for endometrial cancer, followed by radiation for endometrial cancer, and then targeted therapy in endometrial cancer. So, at the outset, I'm thankful to you. As far as the surgery for endometrial cancer is the topic of such a close to heart, everyone feels that he or she knows everything, but still there is something to be added on by the expert. And today we have expert Dr. Kulkarni, head gynae oncology and robotic surgery. He is director in robotic surgery fellowship. We all know him. Kokila Ben Dhirubhai Ambani Hospital, Mumbai. So, Dr. Yogesh, the platform is all yours. Please
Yeah,
go ahead. Yeah, thank you.
yeah. Thank you, madam, and thank you, Parasmi sir. I hope my slides are visible, right?
yes.
Yeah. So I think endometrial cancer has been quite complicated topic of discussion over past 2 years. And over next 10-15 minutes, I think let us keep simple things simple. So we'll just discuss about how we can approach surgery for endometrial cancer. I think why do we need surgery? We have to understand that endometrial cancer is a surgico-pathologically staged disease. So you need to understand the extent. It determines, what adjuvant treatment are we going to give. It helps us prognosticate the patient. You can have a comparative evaluation, and in majority of early stage cases, surgery is potentially therapeutic. So the standard surgery, what we understood over the years, is performing a hysterectomy, bilateral salpingo-oophorectomy, collect cytology, do pelvic and para-aortic lymph node dissection, even in early stage disease, especially high-grade carcinomas, And if there was a cervical involvement, we thought radical hysterectomy was the way to go forward, but no longer it is required. You have to be just radical enough to get negative margins. For advanced endometrial cancer, you have to approach it like an advanced ovarian cancer and perform a cytoreductive surgery. And certain various histological pathologies like papillary serous or carcinosarcoma or undifferentiated carcinomas, you need to do omentectomy and peritoneal biopsies. The most controversial aspect of all this is lymphadenectomy. I think it has been heavily debated over the years, what is good, what is bad, what is adequate, what is inadequate. So, and everybody had their own definition of how they approach lymph nodes. Some would say sampling of enlarged nodes, some would say do a complete pelvic lymph node dissection, or it will be pelvic lymphadenectomy with para-aortic sampling. There are people who would advocate complete pelvic and para-aortic systematic lymphadenectomy in intermediate or high-risk patients. And lastly, there is a new thing that has come, sentinel node mapping. I think the question that we need to address, because 70 to 75% of these cancers are organ confined, and the risk of lymph node metastasis is only about 10 to 12% in stage 1 carcinoma. Does extensive surgery provide survival benefit? And also, can we identify a group that can potentially benefit from lymphadenectomy? I think as far as survival goes, there was a large randomized trial which had shown no benefit of adding lymphadenectomy. This trial has been heavily criticized. Let us keep it aside. But this was the trial which sort of evaluated, the role of lymphadenectomy, especially pelvic lymph node dissection, and they found no difference in recurrence-free or overall survival. There was a similar trial. If you see, the only thing that the lymphadenectomy allows you is identify more patients with positive nodes. So when you did a complete lymph node dissection, 13% of them were found to have positive nodes, vis-a-vis 3.2 when you do a selective lymph node sampling. Now, do we really need this information? And the answer is yes, because the adjuvant treatment in node positive patients is totally different than node negative patients, okay, especially when the molecular typing is not unfavorable, not p53 positive, because both GOG 258 and PORTAGE 3 trial showed us that patients who are lymph node positive definitely benefit by adding chemotherapy to radiation. So we need this piece of information. Now, how do we get this piece of information is how we look at things differently. So by and large, most of the times we do risk stratification of patients, based on histology, based on grade, depth of myometrial infiltration, the imaging findings, whether cervix is involved, nodes are involved, and molecular typing whenever it is available, feasible, and doable. What we want by risk stratification is avoid both under treatment. So let us not do lymph node dissection in a grade 1 endometrial cancer, which is very superficially invasive. At the same time, let us not avoid lymph node dissection in a patient who has a P53 or a high-grade cancer, which is deeply infiltrating the myometrium. So that's what risk stratification does for you. So the problem with this is you are essentially based on histology and imaging, and histology can vary. 8% of the patients are assigned higher grade as compared to what was there on the biopsy, and also the sensitivity and specificity for myometrial invasion. When we are using MRI, which is considered the gold standard, it is still not up to mark. And biomarker panel, which everybody discusses, I think it is very difficult to have all the markers at all the places all the time. So I think that is something that we need to take into account when we do the decision making. And probably one of the most important risk factors, the LVSI status, is not available to you when you are actually deciding to go ahead with the surgery. So this is the classification that I thought will help us. Okay, so you have a low grade tumor, endometrium, or less than 50% of the myometrial infiltration. I really don't think you need to go ahead with a systematic lymph node dissection. I'll see what are the options that are in these patients. Probably a sentinel node mapping would be a very good option in this patient. But for patients who are 1B or who have deep myometrial infiltration, high grade carcinomas, cervical involvement, aggressive carcinomas with myometrial infiltration, I think we need to consider how we can address lymph nodes in this subgroup of patients, because the risk of lymph node metastasis in this group varies anywhere between 15 to 35%. And I don't think we cannot afford to miss that information in these group of patients. So this is where the sentinel node mapping comes. What it helps you in terms of, it takes away the preoperative risk grouping. Even though you are talking about low risk patient, there is still 4 to 7% of them who are going to be lymph node positive, and sentinel node helps you do that. It improves the diagnosis of positive nodes because you are using ultra staging. It can avoid full lymph node dissection and the morbidity associated with it in low risk groups. It simplifies pre-op evaluation. And last but not the least, it defines a real low risk group with negative sentinel nodes who actually require no further treatment based on, obviously, provided the molecular profiling is in favor. The ICG is the agent of choice, indocyanine gene with a near infrared imaging. You give intracervical injection. There is no need to give hysteroscopic or adnexal injections, and the injections are given 2 sites, superficial and deep, at 3 o'clock and 9 o'clock. 1 ml each, so roughly about 2 to 4 milligram of ICG is inserted. This is the most important part of sentinel lymph node mapping. You need to understand this algorithm and follow it religiously. You give the dye, you try to map the sentinel nodes on both the sides, both the hemipelvis. And if you're not able to identify lymph node in one hemipelvis or both hemipelvis, you need to do a complete pelvic lymph node dissection in order to avoid false negative cases. So I think this is a MSKCC algorithm, which is also a part of NCCN guideline. And what it does is, it reduces the risk or false negative chances or missing out lymph nodes when you have not been able to map lymph nodes on one side of the pelvis. And this is another important thing to ask is, what is a sentinel node? A sentinel node, when you give the dye, it's an ICG positive node where you can see a lymphatic going into it. Second is, and these are the group which is most likely to be positive, where you can actually see a lymphatic going into a node, but the node does not show the dye because the entrance of the afferent lymphatics is blocked by the tumor cells. And last but not the least, even though you are doing a sentinel node, if you feel that one of the nodes are enlarged, you need to remove this node and consider them as a sentinel node, even if the dye does not reach there. And ultra staging is a process, by which you analyze the lymph node. So here, what we are trying to do by taking out 2 or 3 lymph nodes, you are trying to judge the lymph node metastatic risk, and you need to be fairly accurate not to miss that. And ultra staging helps you allow that. And I think it's a more or less standard in all the institutions which are using sentinel node mapping. And what ultra staging does is, it helps you to identify the micrometastasis. Now, I won't go into the details. I think the sentinel lymph node studies have shown good sensitivity between 96 to 98% and good negative predictive value between 99 to 100%. The important point here to remember is, almost 1/4, 25 to 50% of patients are diagnosed who are having micrometastasis, which would have otherwise missed if you would have not done ultra staging. So I think that is, in my view, the true value of sentinel node. It allows you to identify patients who even have micrometastasis. Here is a small video of just to highlight what I wanted to say. It's basically you put the dye, you have given the dye, you just wait, start explore the retroperitoneum, and here you can see an afferent lymphatic going into the lymph node. And this is how, if there is a lymph node or there is a green area which does not have an afferent lymphatic, you cannot consider it as a sentinel node. I think unless you understand this, there is a very high likelihood that you may actually miss a true sentinel node, which can be disastrous, for the patient. So if I have to sum up lymph node assessment, in low risk, we should go ahead with sentinel node mapping. For high risk, there are centers which are using sentinel node mapping. We currently use complete pelvic and parotid lymph node dissection along with sentinel node mapping, just to find out, because we have done more than now 90 cases of both. We find the accuracy is same, but we have still not given up doing a complete lymph node dissection in high risk cases, because I don't think the data is adequate enough for us to completely give away lymph node dissection. Open versus MIS, I think surgery is the primary treatment in endometrial cancers. And majority of the patients have body profile like this, multiple surgeries, obesity, multiple comorbidities. And I think open surgery is extremely morbid for this patient. So whenever feasible and possible, minimal access surgery is the way to go forward. And it has been proven by a large randomized trial which showed absolutely no difference in survival. And the risk of port-side metastasis was only 0.24%, which is less than 1%. So I think whenever possible and feasible, minimal access surgery is the way forward in endometrial cancer. Now, laparoscopy or robotic surgery, I think one of the disadvantages of laparoscopy, especially in high BMI patients, is the conversion rate. When you have to do a complete pelvic staging, you can see if the BMI is more than 26, the conversion rate is almost 25%. And as soon as the BMI goes more than 50, it's almost 57%. So I think there is a high morbidity in patients who are assigned or started with laparoscopy and then had to be converted. So that's where I believe the robotic technology comes into play. It allows you acceptable morbidity, it has lesser conversion rate, and it is extremely useful in obese patients. And your assistant will thank you for using the robot in patients who have extremely high BMI, because the robot does all the labor work there for you. Ovarian preservation, last couple of slides. I think this is something that we need to consider, because we are seeing lot younger patients who are coming with endometrial cancers, as long as they fit into the criteria that it's a low-grade endometrioid cancer, no obvious ovarian involvement, less than 50% of myometrial infiltration, no family history of BRCA-related cancers, and they are negative for Lynch syndrome. And even if you are preserving the ovaries, sulfingectomy has to be done along with hysterectomy. Completion surgery, this is another scenario where somebody has done a hysterectomy and the final histopath shows endometrial cancer. And I think here again we have to risk stratify based on histology, imaging, molecular typing, and surgical restaging should be considered only if it impacts adjuvant therapy decisions. So you have an intermediate risk patient who would otherwise not require any surgery. I just have a couple of slides, sir. Who actually doesn't require any adjuvant treatment, and if by doing a lymph node dissection, you are going to change the management, that's the only time you should consider doing a restaging. A patient who obviously going to require radiation or chemotherapy based on the histology and imaging and molecular typing, I don't see any advantage of doing a restaging unless there is a residual disease there. So to conclude, I would say surgery is the key in treatment of endometrial cancer. Risk stratification based on histology, molecular typing, and imaging is absolutely important in planning. I don't think we can exclude either of these three before you actually plan for surgery. Hysterectomy plus BSO is the standard surgery. Low risk, cases, you can do sentinel node mapping. High risk cases, we still need more data before we give away complete lymph node dissection. MIS is the preferred surgical approach, laparoscopy or robotic, whatever is accessible and comfortable for you. And ovarian conservation should be considered in young patient as far as they fit into the strict criteria. Thank you.
Thank you, Dr. Yogesh. Excellent presentation, very crisp and very to the point. We have asked the students to put up their questions in the chat box. If there are any, let me see. Okay, how AI-assisted surgery might change the future of endometrial cancer treatment is the question.
I think AI may change the way AI may risk stratify the patients more objectively, I believe. Okay, I think automation in surgery may also come up to a certain step, but I don't think it see changes, dramatically in near future.
How do you follow up these patients post of this surgery? That's another question that is there. Post surgery, what is your follow up protocol?
I think we call them every 3 months. There is a clinical examination, wall cytology, and imaging. Once in a year, I do CT scan most of the times. Otherwise, an ultrasound or is good enough every 3 months. And if there is any suspicion, we go ahead with CT scan. So every 3 months for first 2 years, and then every 6 months for next 3 years.
And what do you feel is the role for scanning in the form of either CT or PET in your follow-up protocol?
I think we do a CT scan once every year, and we advise for a PET scan only if there is a suspicion of a disease.
Okay, that's I think very well taken, because we find that a PET scan is being rampantly used as a follow-up tool in lot of patients, and lot of multiple PET scans are being done every 6 monthly or yearly also for that matter. So that's a very important point for everyone to remember. Another question: are there new surgical techniques that can improve outcomes? That's another question that has been put up.
So I think the new surgical technique is we have now there are certain centers which are using V nodes along with lymph node dissection, sentinel node mapping. That is one. There is a single port robotic that is being used nowadays, but I don't see. There will be advances in the way the tools that are used for a minimal access surgery. So I don't see anything new that is coming. The approach to surgery may change, and in next 5-10 years, when the data on high risk cancers with sentinel node is robust and mature, I think we may give up lymph node dissection completely in endometrial cancers.
Yeah. Thank you, Dr. Yogesh Kulkarni. I think we have Dr. Parag Binewale, our ICOG chairman, who was he's on the just now on. So, Dr. Parag, over to you.
Yeah, thank you, Dr. Harshad, and good evening on behalf of ICOG. I would like to thank all the faculty and the delegates who've joined here today, and special word of appreciation to all the three conveners, Dr. Harshad Parasnis, who's the past chairperson of Oncology Committee of FOXY, along with Dr. Bhagyalakshmi Nayak and Dr. Sarita Shyam Sundar. Today, the coordinator is Dr. Likhita. I'm sure she has also done a lot of work. I don't want to disturb the flow of the program. Yogesh, the lecture was really good. In spite of being non-onco person, I really enjoyed the lecture. Thank you, all
Thank
of
you.
you, and let's carry on with the program.
Yeah, I think we'll go to the next next lecture on this is by Dr. Bhushan Zhade. He is on radiation for endometrial cancer. Dr. Bhushan is the chief consultant and director of the Department of Cyberknife Radiosurgery, Radiation Oncology at Ruby Hall Clinic. A very enthusiastic person and very much interested in the academics. At this moment, I think he is at Calcutta attending his conference there, but he's found time for us. So I'm thankful to him. Bhushan, the stage is all yours. You have to unmute yourself.
Sir is not joined yet, sir.
No, I can see he has joined. He's joined as Likita Reddy again. I can see him.
Sir, I don't know, yaar.
I can see him. Bhushan, can you actually
Shreya, unmute. Yeah.
unmute?
Bhushan, you can do that.
Okay,
Yeah.
okay, now it's fine. Earlier, I was not able to unmute. I think they did something from backend, and now I'm ready. Thank you, sir. Thank you for those kind words. And I was just watching the previous 2-3 lectures, and it is going in a really nice direction as far as the pelvic or uterine oncology is concerned. And I'll just switch on my presenter view. Can you see my slides, sir, and everyone?
Yes.
Okay, so next couple of, just pardon me if there is some disturbance from my end or some unstable network, because I'm sitting in the corner of hall while attending the conference. So we are going to talk about endometrial cancer and role of radiation therapy as far as the management of endometrial cancer is concerned. So we just understood about the imaging, biopsy, different types of workup when it comes to the diagnosis and staging of the endometrial cancer. And surgery remains mainstay of treatment in endometrial cancer management, unlike cervix, where the radiation is the mainstay, but endometrium surgery is the mainstay of treatment. Detailed histopathology is very mandatory to really risk stratify the patient or the disease, so that we can actually advocate the right kind of a. Sorry, I'm audible well? Hello?
Yes, sir.
Okay.
You're audible.
Yeah. And we just discussed by Dr. Kulkarni, lymphadenopathy role not very well defined in early stages, and probably you guys will be discussing it more. And adjuvant therapy, what we are talking about, radiation therapy is an established modality, and chemotherapy and combination of chemo radiation have been attempted in high risk and ongoing trials are there. We'll discuss, have a word on that also. So this is the FIGO staging. One colleague of ours has nicely discussed this FIGO staging, and these are the ISMO, ASOG, and ISTRO consensus guidelines, which are going to define the role of radiation in the subsequent slides. And whenever we talk about any treatment, there has to be a level of evidence. So we speak about level of evidence 1, 2, 3, and 4. As we go down, the evidence strength goes down, and then we have grades of evidence. So whenever I'll be talking about role of radiation, I'll be mentioning what is the level of evidence about that particular treatment and what is the grade of evidence also. So let us talk about a very early stage endometrial cancer. Surgery is the main state of treatment, no doubt about it, and total hysterectomy with BSO and minimally invasive surgery is recommended whenever possible in the management of the surgical management. And when it comes to adjuvant treatment, this is a staging, what we see, this staging. And then whenever we talk about the selection of radiation or selection of adjuvant treatment, we go by risk stratification. So we have low risk, we have intermediate risk, we have high intermediate risk based on these parameters. So stage 1 endometrioid histology, grade 1 or 2, less than 50% myometrial invasion, no LVSI, it falls in a low risk category. Then we have more than 50% myometrial invasion, still it is grade 1 or 2, LVSI negative, it is intermediate risk category. High intermediate risk, we have a grade 3 histologies, or we have a little higher kind of a depth of invasion. Then we have a high risk category where we have a grade 3 tumors or stage 2 disease or stage 3 endometrioid, no residual disease, nicely operated. And then we have advanced disease to deal with. So let us start with low risk category where we have a grade 1 or grade 2, 1A FIGO disease without any lymphovascular space invasion. So we have a strong level of evidence and good level of strength of recommendation. No adjuvant treatment is required. So this is a nice operated patient. We don't need any adjuvant treatment for this particular category. Sometimes we talk about vaginal brachytherapy as a treatment of as only treatment needed if at all needed. But again, the randomized trials have proven that in this category of patient, even this simple vaginal brachytherapy is even not required. Observation is good enough. Then we move on to the intermediate grade, where intermediate risk disease, where we have 1B, grade 1 or grade 2 tumors, no LVSI. Adjuvant brachytherapy is recommended to decrease the vaginal recurrence. We have a level 1 evidence to support this, and strength of recommendation is A. So very high level of evidence to suggest only brachytherapy, vaginal brachytherapy, only 3 sessions of brachytherapy, 1 week apart, as a OPD basis treatment. No pelvic radiation, no chemotherapy is needed, only vaginal brachytherapy is good enough. Now, if the patient is young, like less than 60 years of age, we can even avoid this vaginal brachytherapy. And again, for this category also, we have a good level of evidence. Then we go to the intermediate risk, but high intermediate risk variety, where we have either grade, stage 1A or B tumors, grade 1, 2, LVSI positive or LVSI negative, grade 3 tumors. So this is a high intermediate risk variety. In this, there is little bit of a division. If surgical nodal staging is performed and nodes are negative, then we need only adjuvant brachytherapy to decrease the vaginal recurrence. No adjuvant treatment is an option also, but in no adjuvant treatment option, the strength of evidence is less. Adjuvant brachytherapy is kind of recommended in this particular set of patients. Now, if surgical nodal staging is not performed, then we need to do a complete treatment, which is external beam radiotherapy, and adjuvant brachytherapy can also be done, but the level of evidence is little on a lower side. So if patient is not really fit for full course of radiation, then probably we can think of adjuvant brachytherapy. Otherwise, the full course of pelvic radiation is kind of recommended. Then we have POTEC 1 trial. All these radiation trials on which the radiation therapy recommendations are based on, these are POTEC 1, POTEC 2, POTEC 3, and different types of this. POTEC is a group of trialists. And so the trial addresses the question, no adjuvant radiation versus adjuvant radiation. And the endpoints are local regional recurrence. And what we see with simple adjuvant treatment, no radiation versus radiation, the vaginal recurrences are 75% less. So we can see this radiation is really indicated in high intermediate risk group patient. We cannot avoid this. Then PROTECT 2 trial differentiate between two modalities of radiation. One modality is vaginal brachytherapy, and the other modality is pelvic radiation, and to see whether these two modalities can have a difference in outcome when we have high intermediate risk group patients. So if you see this busy graph, busy slide, different various endpoints, you can see there is not much of a difference in the pelvic radiation and brachytherapy group. And the quality of life is kind of a poor the patients who have undergone complete pelvic radiation, which is very obvious. So what it shows us that vaginal brachytherapy can also be a standard treatment option for high intermediate risk endometrial cancer, provided there are no risk features like LVSI. But if pelvic radiation would provide better pelvic control with unfavorable risk factors. So you have to differentiate between the high risk, high intermediate risk patients based on the other parameters, which is substantial LVSI, molecular profiling also. In this particular presentation, I am not going to discuss about the molecular classification or profiling because that itself is a huge topic, and some other colleague of mine would discuss that. So I'll stick to the morphological and histopathological part of it. So LVSI, in radiation therapy decision, LVSI plays a lot of kind of a role. A substantial or significant LVSI makes difference in the recurrence rate. So whenever we have LVSI positive patients, the pelvic nodal recurrences are on the significantly higher side. So it is always good choice to add pelvic radiation whenever we have a higher LVSI patient based on PROTECT 1 and PROTECT 2 trial sub-analysis on the LVSI group. The same you can see the increased nodal recurrences LVSI group. Now coming to the high risk patients. So these are grade 3 regardless of LVSI. So if we have node negative in this category, in spite of that, we have to give adjuvant radiotherapy. We can have a conformal fields to avoid higher toxicity of radiation, but adjuvant radiation is indicated. You may consider adjuvant brachytherapy only if we have a patient with low performance status, or if you have patients with not really keen to undergo full course of radiation. But in that subset of patient, the level of recommendation is not that high. So whenever we have a good performance status patient, we should go with a high level of recommendation, and we should advocate a complete course of radiation therapy. Addition of systemic therapy is investigational, chemotherapy is investigational, and the evidence is low. But if we have this high risk patient, in those patients, if the surgical staging, nodal staging is not performed, then definitely EBRT is needed, and sequential chemotherapy considered to improve performance, progression-free survival, overall survival. However, we do not have a high strength of evidence in this group, but it is recommended because sorry, the nodal staging is not done. Then we have a high risk category of stage 2 patients. Again, a simple hysterectomy with lymphadenectomy is done, and node negative patients. In this category, if we have a division of LVSI negative, then only vaginal brachytherapy is needed. If we have equivocally positive or grade 3 tumors, then we need a full course of pelvic radiation and vaginal brachytherapy boost also. Chemotherapy in this category, since nodes are negative, is kind of an investigational. Now, if nodal staging is not performed, so we do not exactly know the status of nodes, so the radiation part remains common. Here, adjuvant chemotherapy or concurrent chemotherapy may have little kind of a requirement to compensate for inadequacy in the nodal surgical staging of this particular patient. Now we have high risk stage 3 patient where radiation is complete course of radiation is recommended, and it improves progression-free survival, and chemotherapy also is needed to improve overall survival and progression-free survival for this particular patient. Now, let us come to a non-endometrioid endometrial cancer. We come across these cancers often. They are not that uncommon. They are serous carcinoma, clear cell carcinoma, and carcinosarcomas and undifferentiated malignant tumors. So here, these histologies have different pattern of failure. They do not fail locally as much as they fail peritoneally or they fail systemically. So in this particular set of patient, unless and until they are very early, they are very kind of a stage 1A tumors, all other all other high risk factors or risk stratification or stage higher than stage 1A, you need to do chemotherapy first, and then we may have radiation therapy as a tumor directed therapy once we are done with complete course of chemotherapy. Now let us come to the POTEC 3 trial. This is very important trial, which is kind of a recently published, and it has changed the way we look at high risk endometrial cancer as far as radiation therapy is concerned. So what this trial did, so with this high risk endometrial cancer patient, we do pelvic radiation as a standard treatment. And then because these are high risk patient, they may fail distally also. So we add chemotherapy in concurrent manner, followed by sequential also as adjuvant carboplatin paclitaxel combination for 4 cycles. Now, with this kind of a combination and radiation alone, we randomize this patient, and then we see the difference. Overall survival and failure-free survival, there is a significant difference in various categories of this particular patient. So this is the overall benefit, taking into account all the histologies put together. And if you see the differences in the histologies, if you have improvement in overall survival by 10%, by 12% in progression-free survival, and then we have a serous histology, which is approximately 30% of that data set patients, we have a significant improvement at 5 years, 18% and 12%. So this trial tells us the importance of addition of chemotherapy over and above radiation therapy. So radiation therapy is there as a base treatment, but we add chemotherapy to that. We improve progression-free survival. We improve overall survival in high-risk histologies. We are talking about clear cell sarcomas, serous cell tumors, and we are talking about carcinosarcomas also. So when we talk about radiation, we are aware about different types of radiation. I am not going to go into kind of a details of different varieties of radiation. Very simple. I'm going to keep this a simple traditional way of giving radiation as a full pelvic radiation, and versus intensity modulated radiation, which is a kind of a conformal radiation. Now, even in intensity modulated radiation, we have different types and categories. We go up to rapid arc, which is a very, very conformal radiation with very less toxicity to bladder, rectum, and bowel. But to keep it simple, I'm just going to quote one article. So, four-field pelvic whole pelvis radiation versus IMRT, a different type of pelvic malignancy taken into account, and you can see the acute toxicities are very less as compared to the conventional way of giving radiation at 5 weeks. So, if you see the different categories of toxicities, they are less with conformal radiation than the conventional radiation. To summarize this talk in a one slide, so I would go this way. We have a low risk stratification where surgery alone is good enough. We have low to intermediate risk stratification where we need to do vaginal brachytherapy to reduce the recurrence. Then we have a intermediate to high where vaginal brachy and sometimes pelvic radiation is needed. Then we have a high risk where radiotherapy is kind of a compulsory, and combined chemotherapy in a select group of patients is warranted. And then we have advanced metastatic disease where chemotherapy comes first and radiation remains kind of for palliation or for specific indications. Then we have molecular markers, but I'm sure my other colleague would have spoken about this or will be speaking about this. So I will not go into details of molecular markers. I'll stick to my topic, which is radiation therapy for endometrial cancer. I think we are open for discussion if anyone has got any question. Thank you so much.
Thank you, Bhushan. I think it was an excellent talk, very precise. I would say that the students would know stage wise what is to be done. I think excellent talk. Let
Thank
me
you.
see if there are any questions, we can permit a question or two. Well, there's a question about what exactly is adjuvant brachytherapy and what is external beam radiation therapy.
Yes. So both are radiation, but when we talk about adjuvant means when after the surgery, whatever treatment we do, it's adjuvant treatment. So brachytherapy is when we treat only the vaginal cuff or vault, which is there after the surgery. So that is the site of maximum recurrences in early stage disease. So we do vaginal brachytherapy. So we insert applicator which goes through the vagina to abut that vault there, and through that applicator we use radioactive source, which is typically iridium source or a cobalt source, which gives very localized radiation to the vault area to sterilize whatever microscopic disease is there. And that's how we improve the local control. And typically this is done once in a week for 3 sessions, once in a week for 3 sessions. And each treatment takes around 15 to 20 minutes depending upon the paraphernalia. And external beam radiotherapy is a pelvic radiation. It's a pelvic radiation where we treat the tumor belt, which is a vault area. We treat the internal, external iliac nodes, obturator nodes, which are the sites of microscopic disease. We do not treat bladder, we do not treat rectum, we do not treat small intestines, but they come in the field depending upon the technique of radiation. But the intent is tumor bed, vaginal vault, and the pelvic nodes.
Thank you. I think, Bhushan, there are still more questions, but if you could just go on to chat and just answer them, that would be for the
Sure,
benefit of
sure.
everyone.
I'll do that.
Yeah,
Yep.
thank you, Bhushan. Excellent talk.
Thank
So
you,
we
sir.
move on to the next talk, which will be by Dr. Chetan Deshmukh. His talk is on targeted therapy in endometrial cancer. I welcome Dr. Chetan Deshmukh. Dr. Chetan Deshmukh is a renowned medical oncologist from Pune, and he's trained at Tata Memorial Hospital, and he has a lot of experiences. He has been part of multiple trials that usually go around in these the treatment of in these cancers. So over to you, Dr. Chetan Deshmukh, and please go ahead with your talk.
Thank you, Dr. Parasnis. Am I audible?
Yes, yes.
Am I audible? Yeah.
Yes, yes,
Are my
yes.
slides visible? Full screen?
Yes, yes.
Excellent. Thank you. Thank you, Dr. Parasnis, for inviting me here. And I must say that the program is really well designed because the molecular aspects of endometrial carcinoma have already been covered in the previous session. So I need not harp on it. A special thanks to my colleague, Dr. Bhushan Zhade, because he said that he highlighted the importance of chemotherapy in the PORTEC trial in stage 3 patients. These are my disclosures, none related to this talk, of course. So I'm not going to harp on the molecular classification, but I just wanted to show you this classification that the three important targets, POL, MMR, and P53. These are three important molecular markers based on which a lot of decision making happens. The treatment as such, we are not going to use all of them. We use only MMR. POL and P53 are not actionable. In the place of these, we have a couple of additional markers. So mismatch repair status remains a very important biomarker for treatment, and patients either have a deficient MMR or a proficient MMR, that is dMMR or pMMR status. Patients with deficient MMR roughly corresponds to what we also known as microsatellite instability high group. The reason why this is important is the approval for the drug pembrolizumab was a very interesting approval. It came as a tissue agnostic, tumor agnostic marker. So any tumor in the body, if it is MSI high, you can go ahead with the immunotherapy drug. That was a very important and a landmark kind of an approval for this particular subtype. Of course, there are additional targets. An important target is human epidermal growth factor receptor, that is HER2/neu. That has been one of the favorite biomarkers in breast cancer, and a lot of research has gone into it. Professor Richard Slayman started doing his work on HER2/neu pathway since 1991, and his work bore fruition in the early 90s and the early 2000s, when multiple drugs targeting HER2/neu have come into the market. And now We also have the homologous recombinant deficiency status, for which ovarian cancer has already proven to be a poster boy or a poster lady for this particular subtype. HER2/neu testing, I'm sure many of you must have seen breast cancer reports with the HER2/neu testing. It is commonly done by immunohistochemistry, which is as well. The test simply measures the level of HER2/neu protein on the surface of cancer cells, and the results are scored as 0, which is 0 or 1 plus, which is considered negative. 3 plus is considered positive. And if you have a score of 2 plus, which is in between, it requires confirmation by an additional test called fluorescent in situ hybridization. Trastuzumab has been the prototype drug, which is a monoclonal antibody designed to target HER2/neu positive cells, which are essentially 3 plus or 2 plus but fish positive cells. How does this antibody work? Remember, these are extracellular domains. The domain gets cleaved, and then the subsequent downstream signal transduction pathway starts off. The antibody blocks this cleavage, and it doesn't allow the extracellular domain to get cleaved. So the subsequent downstream activation pathway is inhibited. In addition, it can also bring about antibody-dependent cell cytotoxicity, and over a period of time, it degrades the HER2/neu receptor. So a HER2/neu positive tumor can actually become HER2/neu negative tumor because of chronic anti-HER2 therapy, and the tumor malignancy signaling based on HER2/neu stops. One of the trastuzumab has been in use in breast cancer since now almost more than 25 years. So we had a lot of experience with that drug. Paclitaxel carboplatin, gynae oncologists have been using it since Willem Maguire got it in 1996 in ovarian cancer. So it was very logical to combine two very familiar drugs. It's a very small study, actually. The patients, barely about 60 odd patients, but this study has a catch. And please understand that this catch or this caveat applies to all subsequent studies which I'm going to stage 4 endometrial cancers, either stage 3, stage 4 cancers or recurrent disease. Most of these studies included 3 and 4 together. Now, when a patient comes to me with stage 3 ovarian cancer, I get two types of stage 3 endometrial cancer. Either the tumor is operated, the patient at surgery has been found out to have pelvic lymph nodes, and the pelvic lymph nodes are rather big, the endometrial mass is rather big, and the surgeon tells me that I won't be able to do a complete job, so why don't you give me some chemotherapy? So these are two types of stage 3 tumors. Stage 4, everybody knows it is metastatic disease, well beyond the scope of surgery. So stage 4 is clear. But stage 3, we have two types of cancers which come to us. These studies, all these studies have included unresectable stage 3 cancer. It may not be a wise idea to group stage 3 and stage 4 together because you need different strategies for different stages. But well, that is how they have done the studies, that they have grouped stage 3, stage 4, and their stage 3 cancers are those which are not operable, essentially unresectable tumors. So they have had some baseline disease, not the type of disease which we have, where we have patients who have come to us after surgery and the pelvic nodes or omental deposits are seen. Now, these patients, in this study, they randomize patients to give standard chemotherapy, paclitaxel carboplatin, with or without trastuzumab. The progression-free survival, the time interval between the actual registration or diagnosis to the first instance of progression after treatment. This is the time period called progression-free zone and almost double, 17 points Zumab. Again, very small number of patients, only 41, but this is the only study. And based on this study, they also showed some slight improvement in the overall survival. The trastuzumab group had an overall survival of 29.6 months versus 24.4 months in the paclitaxel carboplatin alone arm. Based on this, trastuzumab actually got approval to be used in this setting. Then came the other drug. Now, this is the latest kid on the block, the absolute blockbuster molecule in the field of HER2/neu. Why is it different? Well, for trastuzumab to be useful, you had to have a tumor which is 3 plus or 2 plus, but positive by fluorescent in situ hybridization. For TDXT, you can have a tumor which is 1 plus, 2 plus, 3 plus. You don't even need to do FISH, even if it's 1 plus or 2 plus. You can give trastuzumab deruxtecan, TDXT, and be done with it. This was the Destiny pan tumor study. They had 40 patients per cohort, and one of the important cohorts was endometrial carcinoma. And in the endometrial carcinoma group, almost most of these tumors had IHC 3 plus, but there was small number of patients who also had IHC 2 plus, HER2 IHC 2 plus, even smaller number which were IHC 1 plus. But you see the overall response rate, 84.6%. So out of 100, almost 85 people responded to this drug. So almost fantastic response rate. Of course, IHC 0, nobody, the response rate is not expected to be good, but here you see a response because they also received some chemotherapy along with it. And the progression-free survival and overall survival also has been great. In IHC 3 plus, the median overall survival is 26 months. So a significant number of people is they are going to live beyond that. So for a lady with an advanced endometrial carcinoma, unresected stage 3 or stage 4 disease, having a median survival of more than 2 years is something which was unheard of. So this is the latest sensational drug in the armamentarium for endometrial carcinoma treatment. But it comes with a catch. It's quite a toxic drug. It's not an easy drug at all. Interstitial lung disease is one of the most dreaded complications. In fact, in the original breast cancer study, whatever deaths happened because of this drug were because of interstitial lung disease. Vigilance on part of the administering oncologist. You need to stop the drug in time. As soon as the patient starts complaining of cough, breathlessness, you need to initiate steroids when necessary. Get a chest physician on board. Make sure that he helps you in this treatment. But you have to treat this complication in time. Otherwise, it can prove fatal. There are other side effects also: thrombocytopenia, neutropenia, diarrhea, and mucositis. Like all trastuzumab-based drugs, it also has its share of cardiotoxicity. So it's actually a chemotherapy drug in the garb of a targeted therapy. It's as toxic or probably a little more toxic than some of the chemotherapy drugs which we have. Nevertheless, it is probably working wonders. It has changed the treatment paradigms in breast cancer and in many other cancers. In fact, a new trial is upcoming where they are going to use it in patients who have resected endometrial carcinoma. They'll be offering it for a year, and then they will be checking it whether it improves survival over standard carbotaxol and radiation therapy. Sorry. Coming down to immunotherapy, this is again the buzzword in oncology because everybody wants to use immunotherapy. And all four standard drugs have been used in endometrial carcinoma. Dostarlimab, the drug which came into news because 12 rectal cancer patients were disease-free after dostarlimab therapy. So that was a Ruby study, used dostarlimab in recurrent endometrial cancer. The NRG-GY018 study where they used pembrolizumab in endometrial carcinoma. Durvalumab plus olaparib was used in the DUO-E study, and atezolizumab was the ATTEND study. I'm going to discuss only two studies, Pembro and the dostarlimab study, because these were positive studies. If I have time, we'll come to DUO-E study. Interesting study, pembrolizumab, they had a fair number of patients, 800 odd patients. Again, they clubbed stage 3 or stage 4A, 4B together. These patients were given pembrolizumab or placebo along with chemotherapy of paclitaxel and carboplatin. Remember, carcinosarcoma was excluded in this study because traditionally carcinosarcoma doesn't do so well. The administration of pembrolizumab was planned in 6 cycles every 3 weeks, and thereafter there were 14 maintenance cycles every 6 weeks, not the standard 3-weekly therapy. And at the end of 12 months, the patient population who had deficient MMR, the survival was much better. The estimate of progression-free survival was much better compared to the placebo group. And even in the proficient MMR, the survival was not bad, 13.1 versus 8.7 months. Patients who were all comers, they did not use MMR status as an inclusion criteria. All comers were given pembrolizumab, whether you were MMR proficient or MMR deficient, didn't matter. Go ahead, give pembrolizumab. But the benefit is much more pronounced in the deficient MMR status. These are the Kaplan-Meier curves, and you can see that the gap between the blue line of paclitaxel placebo and the yellow line of paclitaxel pembrolizumab is very wide. You can keep a whole thumb in between the two curves for the deficient cohort compared to the proficient cohort. In the initial part, in fact, some of the curves are almost overlapping and kissing each other at a couple of places. So the benefit is more pronounced in the deficient MMR, benefit is more pronounced in the deficient MMR cohort compared to the proficient MMR cohort. Same thing about dostarlimab. Only thing is here they have also included carcinosarcoma. Almost 11% of patients had carcinosarcoma. Here they have given maintenance dostarlimab for 3 years. So long duration of therapy. But the progression-free survival at 24 months was 36 versus 18%. So almost doubling of the PFS. And the overall survival at 24 months was 71%. So 71% of the population is going to be alive at 2 years, which is again a very good thing. Same thing, same story of pembrolizumab repeated with dostarlimab. Deficient MMR cohort, the curves are wide apart. Proficient MMR, the curves are rather close to each other. Well, they are still separate, but nevertheless, they have some amount of gap is seen. Cost is the major deterrent to this therapy.
Sorry
today.
to
The
interrupt
side
you,
effect
sir. Your
profile
time is
essentially
up.
yeah, just last slide. Just let me, this is a side effect of immunotherapy. Side effects essentially, common side effects like skin changes, rash, pruritus, liver derangement. Rarely endocrine disturbances like thyroid, adrenal insufficiency, and hypophysitis. Rarely diabetes. But hypersensitivity pneumonitis is one of the most troublesome, fortunately amenable to treatment with steroid. So this was, the idea was, treatment based on molecular profile is going to be our way forward today. Immunotherapy plus chemotherapy is going to be the standard for stage 3, stage 4 endometrial carcinoma. Of course, I couldn't talk much about the HRD-based therapy, but that is also one of the options. Olaparib may have some benefit in endometrial carcinoma. What we need are predictive biomarkers which will identify those responders so we can offer this costly therapy, potentially toxic therapy, only to those who are likely to respond better. Thank you, and sorry for shooting off my time. Thank you.
Oh, I think it was a good presentation, Dr. Chetan. Very informative, and I think this everyone needs to understand that you have to use these weapons with care and to very selected patients. Patient selection appears to be the most important part here, and it cannot be administered to every other patient just because she's from the same stage or has the same similar molecular status. So you have to identify them. If there are any questions, let me see on the chat group. Uh, okay, fine. If there are any, I think they can get back to on the chat to Dr. Chetan Deshmukh, and
Sure.
he could answer them.
I'm around. Yeah.
Yeah.
Sure. Thank you.
I think that over to Likita.
Yes, sir.
Yeah.
Thanks to Dr. Parasnis sir and Kavita Singh ma'am for being chairpersons of this session, and to the speakers of this session, Dr. Yogesh sir, Dr. Bhushan sir, and Dr. Chetan sir. Moving on to the last session for today. The topic is on management of vulvar cancer by Dr. Deepanvita Banerjee ma'am. Ma'am is specialist gynec onco at Chitranjan National Cancer Institute, Kolkata. Over to you, ma'am.
Thank you, Likita. I hope my slides are visible.
Yeah.
Okay. Thank you, Dr. Harshad, for giving me this opportunity. So in the next few slides, I will be discussing on the brief overview on the management of vulvar cancer. So I have not prepared this PPT with the help of any artificial intelligence tool. So the vulvar cancer is rare, accounts for around 4% of all gynae cancers. According to Globocon 2022, there are around 45,000 new cases along with 17,000 deaths. Squamous cell carcinomas account for more than 80% of cases, followed by vulvar melanomas. Other histological types are rare: verrucous, Paget's disease, adenocarcinoma, Bartholin gland carcinomas. This is a disease of mainly postmenopausal women. Mean age at diagnosis is approximately 65 years. The most common site is labia majora. To present with 10% cases, the lesion is extensive, whereas in 5% of cases, the disease is multifocal. So to start with the anatomy, we know it consists of the prepuce, the clitoris, the labia majora, the labia minora, and the vestibule. The fourchette can be divided into anterior and posterior, the posterior commissure and the fossa navicularis. So the anatomy of vulvar lymphatic drainage is very important to study because it has the very ipsilateral as well as contralateral drainage to the superficial and deep inguinal lymph nodes, and there are certain areas like clitoris and the midline lesions who can extend directly to the have a cross extension of the lymphatic pathways, as well as can go directly from the second basin is the pelvic lymph nodes. So the anatomy of lymphatic drainage of vulva is very important to study. So how do we do the pre-treatment workup in a case where patient presents with a vulvar mass or lesion or with a history of chronic pruritus vulvi? Usually in the history, the younger patients have HPV-associated infection and the history of smoking. In elderly patients, those are mostly has a background of long-term pruritic lesions. Unifocal in nature, is of differentiated VIN to set with, and often not associated with HPV infection. The clinical examination, the description we have to see the size, whether it is unifocal or multifocal, distance from midline, the distance to important structures like anus, urethra, and clitoris. And again, I am telling it that the inguinal region should be carefully palpated because inguinal lymphatic nodal metastasis is the single most important prognostic factor in vulvar cancer management. All this is required because the first primary treatment of vulvar cancer is surgical planning. So how do we diagnose? To take a punch biopsy under local anesthesia by a Keys punch biopsy, what we call the multiple vulvar lesion. All lesions should be biopsied separately with clear documentation and pictorial explanation of the lesions as well as the origin, where from the site of the lesion, where from it is coming. The pap smear or cervical cancer screening or colposcopy of cervix or vagina is as and when required, because it is the vulvar cancer also comes into the HPV spectrum diseases. So it is important to do the screening for cervix as well as the other anogenital area. The picture or clinical drawing is advised. The suspicious inguinal groin nodes should be biopsied. A preoperative biopsy report, the histological type and depth of invasion is required. So lymph node status is the most important determinant of survival, whereas 20% of positive groin nodes have positive pelvic nodes, which immediately takes the case to thus upstage the disease to stage 4. The metastasis to pelvic lymph nodes are uncommon. The lymph node resection is performed through a separate incision for during surgical treatment from the primary tumor and may entail ipsilateral or bilateral or sentinel lymph node biopsy in select cases. The pelvic nodal mets are rare in the absence of clinically suspicious groin nodes. When the groin nodes are less than 2 in number are positive, and tumor with depth of invasion less than equal to 4 millimeter. So why, again, I am forcing it that status of inguinofemoral lymph nodes is single most important prognostic factor, because if it is negative, the survival rate is more than 80%, whereas the node, when comes as positive, the survival rate drops below 50%. So, and the number of nodes in all the recent guidelines has stated that single microscopically positive has similar prognostic factor as negative nodes, whereas 3 or more. But the nodal metastasis, which has an extracapsular extension, even with one positive node, survival reduces from 80% to 44%. There are various studies to support this evidence. junction of normal and abnormal tissue in preoperative workup, and the depth of invasion is measured from the basement membrane of the deepest adjacent dysplastic tumor-free reach to the deepest point of invasion. In preoperative workup, the imaging in patients were considered for sentinel lymph node procedure. Imaging by ultrasound is recommended, though with poor evidence. In all other cases, systemic staging by CT or PET-CT is recommended. Even the FIGO 2025 also is recommending the update on FIGO 2025 is also recommending PET-CT especially for when the extensive surgery is planned. Evaluation of extravascular structures with MRI is recommended. Extravalvular structures is MRI is recommended, and specialized centers with available trained ultrasound examiners. You can think about ultrasound can be an option. So the imaging in vulvar cancer, primary tumor site, ultrasound and MRI. For the distant organs, we can think about CT scan and PET-CT for metastatic workup. The new FIGO staging 2021, I am not going into the detail, but it is more simplified. And the changes which was done from the previous 2009 staging is the depth of invasion, which has been measured. And the previous definition was measured from epithelial junction of the most superficial dermal to deepest point, lymph node status, incorporation of cross-sectional imaging and staging for all types of morphological types of vulvar cancer, and documentation of HPV status is very much recommended. The principles are depending on the individualization of treatment, MDT approach, gynae oncology center referral, and the vulvar conservation with unifocal tumors and an otherwise normal vulva. The stage, early or localized stage 1 and 2 is considered early stage, whereas locally advanced is stage 3 and 4A, whereas the advanced disease is stage 4B. In stage 1A, it is microinvasive vulvar cancer, lesion measuring 2 cm or less. The treatment approach is radical wide local excision, and groin node dissection is not necessary as there is less than 1% risk of lymphatic mets. Whereas in stage 2B, lateralization, either radical partial vulvectomy or with have to address the lymph nodes either through inguinofemoral lymph node dissection or sentinel lymph node biopsy, whereas the lesion is central. It should be a radical partial vulvectomy with bilateral inguinal femoral lymph node dissection or sentinel lymph node biopsy. Please, all of you, go through the vulvar guideline management through NCCN 2026 version 1, which has been published recently, and you can go all these flowcharts, which is very much informative and is in alignment with what I stated right now. The negative margins, if after the surgery is negative, then adjuvant therapy can be is not required, or adjuvant external beam based on other risk factors like positive margins, re-excision if possible, or if not unresectable, then in case that adjuvant DBRT is required. So the vulvectomy are skinning, simple vulvectomy as well as radical vulvectomy, whereas the skinning vulvectomy is not recommended in managing the vulvar frank cancer cases. The more and more conservative approach is coming out, and radical vulvectomy or radical local excision, where you have to go to the depth of invasion to touching the urogenital diaphragm, is required for removing the whole taking out the whole depth of invasion and measurement by the pathologist. So what the modified radical vulvectomy is, the incision is still the inferior fascia of urogenital diaphragm, individualized depending on the sparing of the vital organs. Primary closure is maintained in most cases. If required, indication is in usually stage 1B, 2 and 3 selected unifocal lesions. There are various flaps, and reconstruction is possible where if you can go, or it is indicated, but in highly specialized centers. So modified radical vulvectomy is a radical removal of vulva containing the tumor with approximately 1 to 2 centimeter margin, with usually given by the triple incision, minimizing anatomic alterations and disfigurement. So the inguinal nodes are addressed separately by 2 separate incision, and the whole vulvar lesion is addressed by the another incision, whereas traditional conventional butterfly incision is not recommended now. Now regarding the margin, there was previously it was thought that 8 millimeter margin is very much important, but where more and more it has been seen that effort should be made, and NCCN and other FIGO 2025 is also recommending that effort should be made to obtain an adequate gross negative surgical margin but which depends, or it is not very specified, because it has been seen that the recurrences which happens on the vulvar cancer is mostly a new lesion is on the same field, rather than because of the positive margins, previous negative margins or close negative margins from the previous cancer surgery. So for the stage 2, radical wide local excision in select cases and radical less than equal to 4 centimeter. Please go through these flow charts, which is there in the NCCN guideline. Please download it. It is freely downloadable. Where the residual tumor is there, you have to see the margins are negative. Margin negative is of utmost importance. The advanced vulvar cancer multidisciplinary team management, the status of groiners should be determined before treatment is planned. Clinically suspicious node should have fine needle aspiration, pelvic CT MRI or metastatic workup for imaging is required. The surgical excision of the primary tumor with clear surgical margins without sphincter damage is possible if required, because more and more the exenterative surgeries are often discarded and is not very much promoted in recent surgical management of CA vulva. Full lymphadenectomy should not be performed because of a full resection followed by groin irradiation may result in severe side effects like lymphedema. So ulcerated fixed groin nodes should be biopsied. No incomplete response to radiation, nodes may then be resected if appropriate. Alternative strategy is to use neoadjuvant chemotherapy. The stage 4B, where there is distant metastasis, concurrent chemoradiation, mostly the treatment is palliative, and there are CheckMate 358, the other keynote studies, which have shown that there is a role of pembrolizumab or nivolumab in the form of immunotherapy in metastatic advanced surgeries. Advanced vulvar cancers. The neoadjuvant chemotherapy in locally advanced vulvar cancer, there are no randomized controlled trial, but there has to be a multidisciplinary assessment, which can be an option, 3 to 4 cycles of chemotherapy. Restaging and reassessment regarding definitive treatment should be performed. Treatment should be highly individualized. Now, a quick discussion on sentinel lymph node biopsy. The concept is that initial site of Mets disease and the histology of the sentinel node reflects the histology of the rest of the lymph nodes in the basin. Advantages: less edema, less wound complication, and the standard of care approach for lymphadenectomy in select patients according to various trials which has come up, like Groins V1, Y2, and GOG 273. Distant nodal mets in the sentinel node omit a full lymphadenectomy and avoiding the side effects. The indications are unifocal tumor, less than 4 centimeter diameter. I think my time is over. Yeah. So sentinel lymph node is just 2-3 slides. The dyes which are used, the prospective studies, the blue dye, technetium alone, and combination of blue and dye. This is a summary. Again, go to the NCCN guideline. In case of recurrence, there has to be, the treatment should be individualized, vulva confined recurrence or vulva distant recurrence. If it is partial or vulvectomy is done, margins have to see whether it's a small recurrence or it's a organ involving recurrence. The confirmed nodal mets, isolated or distant mets, EBRT, NSCT, EBRT, NSCT surgery whenever it is possible and wherever it is applicable. The follow-up is interval is 3 to 6 months for 2 years, 6 to 12 months for 3 years. Then clinically suspected recurrence, imaging and consider biopsy of everything like other surgeries. A quick slides, 2-3 slides on rare histologies: melanoma, Bartholin gland cancer, and Paget's disease of vulva. Melanoma is, according to the AJCC stage, role of removal of nodes are not very much indicated, or only remove only nodes which are clinically involved. So treatment of choice is surgery. The role of immunotherapy is there. Bartholin gland, go for the Honan's criteria, go see that. And radical local excision alone is adequate treatment for with bilateral groin dissection for Bartholin gland cell cancer, whereas the rarer types, adenoid cystic, at their radical local excision is alone. Paget's disease, different whole topic altogether, can be a pre-malignant or malignant. but there is a high chance of recurrence, so you have to go. Surgery is always excision and re-excision, but recurrence rate is high, and long-term follow-up in a specialist vulvar clinic is required. So the take-home message is the major challenge is multimodality treatment is required. Treatment decision should be made by multidisciplinary team and individualized. Most of the data are extrapolated from other cervix or canal. More research in this field are needed for better understanding of the disease. Thank you so much.
Thank you,
I
Dr.
think I could do the justice.
Thank you, Dr. Dipanvita. It's a huge topic. I can understand that it's
Yeah,
a
it
huge
is.
topic, and trying to make it concise for the students' sake into a nutshell is really a Herculean task. But I must still say that you were able to give us the gist that vulval cancer surgery still remains the cornerstone of the treatment, and radiation and chemotherapy, these are a secondary line of management for all you know. So thank you very
Yes.
much. I think we are short of time, so if there are any questions on this, we would ask the participants to put it in the chat box so that they could be answered by Dipanvita. Likhita, over to you.
Yes, sir. Thank you, Dr. Dipanvita, ma'am. Moving on to the panel discussion on management of vulvar lesions. Moderator for this session will be Dr. Ashok, sir. Sir is Associated Professor in Gynec Oncology at APHG Institute, Odisha. And the panelists for this discussion are Dr. Sampada Desai, ma'am, Dr. Salil Barsode, sir, Dr. Vinota Thomas, ma'am, Dr. Prashant Nyati, sir, and Dr. Colonel Vinod Dalal, sir.
So, good evening, one and all. So, at the outset, I'm thankful to the ICOG team, including Dr. Harshad Paransis, sir. And today, I've been assigned to conduct a panel on case-based discussion on malignant lesions of vulva. So, today's panelists are Dr. Silpi Verma, Dr. Sampada Desai, Dr. Salil Parshod, Dr. Vinota Thomas, Dr. Prashant Nayati, and Dr. Vinod Dalal. I think all of them are there. Dr. Harshad, can you confirm that all these panelists are there?
Yeah, I think Dr. Shilpi Verma, who was not able, there was a family medical emergency, so she had to just rush. So she is not there. I think rest of them are there.
Okay. So this is a case-based discussion. So without wasting time, straight away we'll go to the case. So before the case, just one thing is that what is the purpose of doing a panel is that alone we can do so little and together we can do so much. Coming to the case proper, this is Mrs. X, 56 years, postmenopausal lady for 10 years, and menopause since 10 years, with a history of itching and lesions over the perineum and lower limbs for 3 years. Diagnosed in derma OPD as lichen planus and was on the local treatment. Referred to gynae oncology OPD for further management. So when we examined the patient, we found there is a hyperpigmented lesion on the vulva with satellite lesions over the perineum. Her speculum was cervix is atrophic, first with vagina. Per vaginum, uterus is atrophic. We took pap smear, it comes to be HCl. And we did vulvoscopy, found hyperpigmentation with multiple acetoid areas on vulvoscopy. Coming to colposcopy, we did colposcopic examination, found a type 2 transformation zone. Ectocervix is acetoid areas at 8 to 10 o'clock and 11 to 1 o'clock position. No abnormal lesions, iodine uptake patchy. Acetoid area on the upper posterolateral vagina is also there. Did proctoscopy, it was absolutely normal. With this, my question to Dr. Silpi, but Dr. Silpi is not there, so anybody can take these questions. So what to do? How to proceed in such situations? So the next panelist is Dr. Sampada is there?
Yeah, I'm there. So whatever, since cervical cytology is HCl, we will like to evaluate the cervix further in the form of leap or a cone biopsy. Vulval lesions are there, so those lesions also need to be biopsied. All lesion individually need to be biopsied with taking adequate samples from the biopsy, and even the satellite lesions needs to be biopsied.
So I think if the cervix, if you are getting acetoid area, is it cone biopsy is indicated, or you can go to simple punch biopsy? I think simple punch biopsy is enough also. So what's your take on this?
About the cervical biopsy, we
Yeah.
should be doing a colposcopy of the patient.
Multiple punch biopsy from accentuate areas, I think enough. It's no need to go for a cone biopsy straight away in this such scenario. So, can you tell that how to take proper procedure for taking a vulvar biopsy? So, how it is taken? I think it is covered by Dr. Diponita in her talk also. So, how to take a biopsy properly and to evaluate. Dr. Sampada, are you there?
Yeah, I'm there. So, punch biopsies are taken with the punch biopsy forceps.
What is that
For
particular
the
name of that forceps?
case,
Yes, it's case punch biopsy forceps.
and vulval biopsy, when it is not possible, if there might be not be a growth always, so sometimes it might
Yeah.
not be possible to take with that punch biopsy forceps, so you will have to do a
Okay.
incisional biopsy in that case.
Okay. So, any particular test you need to do after the specimen you send for biopsy. Along with that, any extra test you need to advocate to the pathologist.
Yes, we do routinely P16 and P53 because further
Okay.
on.
These are required. These are the
Yes,
common
yes,
things, ISC markers that is required.
yes,
And you will need to go for colposcopy also.
yes.
And also inspect, never try to forget the perianal area, because if you're getting a lesion, definitely you know to go for this proctoscopy and the nearby areas which may contain some lesions we may miss out. So you need to examine these things properly. So in our case, we did cervical biopsy, multiple punch biopsy, and it shows that acute cervicitis with patchy foci of mild to moderate dysplasia. See the term, with neutrophilic infiltrate in the epithelium and hemorrhage in the subepithelium. We took the multiple vulvar biopsy, it comes to VIN3, and biopsy from the satellite lesion and the perianal regions is VIN2. We do ECC, it comes disease inadequate. So now the question to Dr. Sampada is histopathology report of VIN3 and VIN2 consistent with the latest classification of VIN, and what is the latest terminology? Can you throw some light
According
on
to
it?
the latest classification, this VIN 2 and 3 is not the latest classification. We now classify them into, according to WHO classification, into HPV associated and HPV not associated with HPV. And VIN 2 and 3 of the previous classification will fall into HPV associated and falling into the group of HCl.
HCl. Okay. And what are the different varieties of HPV independent? Can you throw some light on that?
Yeah, they
What are
again
types of
classified.
HPV independent?
Yeah,
Yeah.
they are again classified into three, like differentiated VIN, exophytic vulval VIN, and that associated with acanthosis.
Yes. So HPV independent are again Devian, Devil, and Fart. So the next question to Dr. Salil. Dr. Salil, are you there? So how to differentiate between vulvar HCl, that is VN2 and VN3 and DVN, and how does ISC help in differentiating the lesions? Dr. Salil? Dr. Salil is not there. I think Dr. Diponita might be is there. Diponita, are you there, my friend?
Yeah.
Yeah, we can ask her to join in. Yeah, please do.
Yeah, you can join also in this panel. So how to differentiate the vulvar
I have a
HCl?
session from 7 p.m. So I will be
Okay,
here
it's
till
not
7.
7.
Yeah,
Half an
please.
hour is there. Okay.
Please tell me.
So how to differentiate between vulvar HCl and DVN?
So vulvar HCLR is usually, as I said, that it's a younger population where it has a multifocal disease and mostly HPV associated. And
Yes.
the DVIN usually is in the elder population, which is not HPV related and has a long history of pruritus valvi, long-standing history of pruritus valvi. So these are the clinical feature by which we can differentiate between vulvar HCL and DVIN lesion. And
if you want to put,
as I think,
yes, if you want to
yeah,
put the
so
acetohyte, how it differentiate?
yeah, so that because the basic principle of acetoviteness is that in HPV associated illnesses, there will be the acetovite area. So which you can see that it will be like the acetoviteness will be there for the vulvar HSIL lesions, which are mostly HPV associated, whereas the
Yes.
DVIN will not take it will not have the aceto whiteness uptake. Because the etiopathogenesis is different, both the cancers,
Different.
both
Yes.
the lesions, huh?
So
So it
how
will not
ISC
take
helps?
uptake.
How ISC
I
helps
see,
in
I
different?
see again, it is again related to HPV. So HPV is
Yes.
P16 positive, and usually the DVIN does have around 30%, 15 to 30% chance of having vulvar cancer. So
No. Yeah.
for the ISC, it is like it is P16 positive, the vulvar HSIL lesions, which is again shows the HPV link to it. And whereas the DVIN will have a P53 mutation, as well as it will be not P16 positive, it will be
But
P16
it's not a
negative
block
in
type of
majority of the
P16
cases.
block. It's
No,
not a block
it will
type.
be a patchy. It will be a
Patchy. So
patchy.
maybe,
If
so
it is
maybe
positive, so there it's the for the HSIL lesions, the P16 would be block positive, whereas the
yes, yes,
DVIN, if it is
yes.
P16 positive, it will be patchy.
Patchy. And you can take another two, P53. Usually P53 is negative in the vulvar HCl, which is positive in the DVIN. And again, if you're taking the case Ki67, Ki67 is entirely positive throughout the epithelium, where it is only positive in the basal layer, because the pathology remains in the basal layer. So, if you go to the European guideline, ISSBD, all the guidelines also differentiated this vulvar HCl and deviant basing on this three ISC marker, where it is clearly indicates that P16 is block positive, as mentioned by Dr. Diponita for vulvar HCl, where Ki67 extends above the basal layer throughout the entire epithelium and vulvar HCl. At the same time, if you see, there will be aberrant P53 staining patterns in DVIN, and P60 is not block type, it is a patchy type one. So that are the two important ISC markers that differentiate between vulvar HCl and DVIN. So now the question is how to Dr. Salil, I think how to differentiate between DVIN and DEVIL by ISC. That is another also ISC markers that can be taken care of, that will take care of to differentiate between DEVIL and VAD. So if you, again, the same thing, Deviant is P16 negative, you know that it is not HPV associated, and it is P53 positive. Whereas Devil, it is P16 negative and P53 also negative. And for extra ISC markers, if you know, then P53 wild type in Devil VAD, along with some somatic mutation in PIK3CA, Notch1 and HRAS also. So, Dr. Binod, are you there?
Yes, sir.
I'm there.
Dr. Binotha, the questions to you is what are the various modalities of treatment available to treat pre-invasive vulval cancer and how to treat?
Dr. Vinod, and Vinotha is different.
I'm asking Dr. Binotha Thomas.
Yeah, okay.
Dr. Binotha.
Yeah, thank you. I didn't know there was a Dr. Vinod on this panel. Sorry. Uh, various modalities. I think surgery, surgical
Yes.
excision would be the best option and should be definitely considered, and especially in differentiated VIN, because they have high risk of concurrent either harboring a malignancy at that particular point in time, or they have high risk of transformation for malignancy. So surgical excision should be the first choice. However,
Okay.
we talked about vulval HSIL in younger patients, and as the Dipanvita mentioned, it is multifocal. Uh, Surgical excision could be quite aggressive for them. If surgical excision is not possible, and we want to preserve the organ, in those patients, medical therapy can be offered.
So is there a role of ablative treatment? So if you're telling about excisional treatment, it's okay, but there are also certain conditions because
Yes,
you have to
so
individualize the treatment. So what are the cases where you need to go for ablative treatment?
so again, multifocal disease, again,
Yes.
using CO2 laser, we can off, but we should make sure that even the hair follicles are destroyed. And be careful about the depth of laser vaporization. It's
Yes.
important to get adequate biopsy of before laser ablation.
Yes. So is there any role of medical therapy? So different options are just.
So yes, medical therapy is best for those with vulval HSI, not for DVIN. So
Okay.
what we have available in India is 5% mode.
And the way we apply it is also very important because it is Mucimode acts by causing it's almost like creating an immune response. So they have a lot of side effects like fever, myalgia. So we need to slowly increase it to thrice a week. So we start with once a week application, apply it for 8 hours overnight, wash it off, and apply a good emollient on top of it. Then slowly it to 2 times a week and then 3 times a week.
Any side effect you have, any
Yes,
adverse
as I
effect you have
mentioned, they have
encountered in your practice?
yes, they have a lot. If we quickly just go up to thrice a week, then they have all these problems like fever, severe erythema, local reaction. So it is
We have
important.
seen a severe local reaction from a burning. They usually cause severe burning. It's not able to tolerate that many times.
So it is
And most of the patients have that type of
yes, so it is
complaints.
important to slowly escalate it to thrice weekly application and not straight away go to thrice weekly application.
Yeah. So the rightly mentioned management options of herbal HCl include excision, ablative therapy, and topical treatment. Decision to choose must be individualized, depending upon the examination, biopsy result, prior treatment history, and location, and locality of the lesions. An ablation and medical therapy must be preceded by several representative biopsies to exclude malignancy. In vulval pre-invasive lesions treatment, surgeries resulting in significant distortion of vulvar anatomy should be discouraged. That should be taken care of, and because leads to lots of disfigurement. That is very important. That should be taken care of while dealing such cases. So, Dr. Prashant Nayati, my friend Prashant, are you there?
Yes, hi. I'm there.
Yeah. How are you, Prashant?
All good. Thanks. Yeah.
Yeah. So, for the question for you is, what is the best option for this particular case we have discussed, and what are the further plan of dealing with concurrent cervical pathology? And it has a cervical pathology that is in form of CN2.
Right.
So, should cervical and vulval pathology be dealt at the same sitting or separately? So, what is your
So
take on that?
definitely, she is 56 years old. So definitely, we should deal with both of them, cervical as well as the vulval.
Yes.
Prioritization is important. So,
Mhm.
but since this lesion, what you have written is on the colposcopy, it is 10 o'clock, 12 o'clock, and 6. So, quite a wide. So, therefore,
Yeah.
in this case, we can prefer a deep conization. So, that should
Yeah.
help in the cone cervical part. And since they are
Yeah.
satellite lesions also, so this is not a unifocal, this looks like a multifocal. So then
Mhm.
definitely if we can do a proper vulvectomy because she's 56 and she has
Yeah.
multiple lesions. So I would think a
Yeah.
vulvectomy should
Yeah.
suffice in this case, no need of any further year. And
Yeah.
it should give a good cosmetic outcome also.
Yes. Since it's a pre-malignant region, no obvious growth was there. So we can
Yes,
go for skinning vulvectomy. So what we did
yes,
actually in this particular case is the skinning vulvectomy with cervical conization with vaginal biopsy.
okay.
There is a lesion acidoid area in the vagina also, posterolateral area, and excision of
Okay.
the satellite nodules too. So before that, we want to just ask this question to Dr. Binod. Are you there, Dr. Binod
Yes,
Dalal?
sir. Yes, sir. Yes, sir.
So what is the differences between the skinning vulvectomy, simple, because these are the terms you usually encounter in your practice: skinning vulvectomy, simple vulvectomy, wide local excision. What are the basic differences between all this type of vulvectomy?
The basic difference depends on the depth of excision. So, like in
Exactly.
skinning vulvectomy, it is superficial vulvectomy where we are dealing with the only with the epidermis part, and we are not
Okay.
touching the hypodermis or the subcutaneous tissue. And
Yeah.
in simple vulvectomy, we are taking a layer of subcutaneous tissue also, that is the hypodermis. And so
Yeah.
it is basically the depth. When the disease we are treating simple vulvectomy for a localized disease, we generally take a wide local margin, free disease margin of around 1 centimeter. So it becomes wide local excision.
Yes. So this is the basic difference. Skinning is only limited to the skin, as correctly mentioned by Dr. Binod. And if simple, you have to go for little bit deep. That is superficial portion only. That is superficially simple vulvectomy. And in wide local excision, the intent is again is a margin of 1 centimeter you have to take. So we are not covering radical vulvectomy, partial vulvectomy. This is not actually applicable to this kind of lesion here. And when you analyze the histopathology here, we found in skinning vulvectomy specimen, it is VIN3, it was written, with right lateral and left lateral, and inferior margins are positive for VIN3. in skinning bulbectomy. And right satellite lesion, it is again VIN3. We took vaginal biopsy, it comes to be fibrocollagenous tissue only, no lining epithelium. And cervical cone biopsy, it is comes to be CIN3, but there is negative margin for cervix. But for bulbectomy specimen, it is the margin is positive. So Dr. Sippy is not there now. Dr. Sampada can take this question, or Dr. Diponita, if you are there, you can take the question. How to deal with positive margins of bulbectomy specimen, particularly this such type of case where it comes to be positive, and does it require re-excision? Dr. Sampada?
Since it is VIN3, we need not excise the margin. We can keep it on the close follow-up.
Yeah.
And every time that we follow, we check, especially, we will be checking everything, but we have to explain to the patient that that margin is positive, but there was no invasive tumor there, so we may not re-excise at that point of time.
Exactly, and so many literature starting the ISSBD, ESGO, everybody is all these international bodies are in favor of that. In case of positive margins, after surgical excisional treatment of particular vulvar HCL, if clinical inspection does not show a residual lesion, patient must be followed only, and immediate re-excision is not at all recommended. So, but at the same time, if you have any medical treatment, can you apply on that for this margin if comes to positive? You can also think of a medical treatment for this positive margin in form of imiquimod, which is described by Dr. Binoda correctly how to apply that. I'm not going to details of it. So Dr. Sampada, are you there? Again, this is question for you. What is the follow-up protocol for post-excision and what to do during follow-up? If the patient comes to you with follow-up, so what to do and how frequently you follow? What is the protocol?
We follow them up every 3 to 6 monthly, and we do a clinical examination. Since there was a vulval, there was CIN3 also there, so we will do repeat a cytology after a year, and
also
vulvoscopy and a colposcopy if required, but not as a routine part of every 6 monthly or 3 monthly follow-up. Clinical examination is the most important part of it.
Exactly. If you go for this British guideline, BGCS guideline, it clearly mentions that follow-up after initial treatment varies, but 6 monthly. It should be 6 monthly follow-up for 2 years, initial 2 years, then annual follow-up up to 5 years. That was the recommended. But again, I have to also stress upon, particularly giving stress on women with deep VIN or lichen sclerosis, because they are more prone to develop cancer in more than 50% cases. So they need long-term follow-up. And follow-up with high-risk HPV associated disease should be guided by clinical judgment. That is not mandatory that every time you should go for this vulvoscopy and a colposcopy. But follow-up with formal vulvoscopy is recommended, but methodical clinical examination by accredited vulval specialist is most important nowadays. So visual inspection and digital rectal examination at the same time, so you need not neglect the anal area or perianal area. You need to also go for digital rectal examination if there is any perianal or anal disease also. That to be taken care of. So we follow up the patient again in April 2007. This patient come with a right inguinal node swelling. So we took the biopsy. It comes to be reactive lymph node, and no granuloma or no malignancy was found. 2007. Again, the patient was under our follow up again. Again, she comes in after 2 years. Again, October 2019. But at that particular moment, she had a complaint of severe vulval itching and the lesion. There was a lesion also. And she was describing that this is there since last 3 to 4 months. And when we examined the patient, we found there is a 1 into 1 centimeter verti lesion near the clitoral hood, and 4 other 1 centimeter lesions seen in the right labiocrural fold and 1 verti lesion near the anal opening. You can see I have just mentioned clearly with this reddish mark. If you see the picture, you can see there is a 1 centimeter verti lesion in the clitoral hood, again with 4 other lesions, and another 1 verti lesion in the near the anal opening also. So how will you manage in such cases, Dr. Salil? Now, because now it becomes a recurrence. So how to manage?
Dr. Salil is not there, so let's ask Dr. Vinod Dalal.
Dr. Binodha?
Not Vinodha, Dr. Vinod Dalal.
Dr. Binod.
Sir. Yes, sir. Sir, like in this case, it's a recurrence of the disease with multiple lesions and involving the clitoris. Definitely we have to prove the disease. So we have to take multiple biopsy. That is the first priority, because we have to prove and we have to rule out malignancy also in this case.
Yeah.
And once we have done that, and if the biopsy histopath, along with that, like any other general visit, we have to during the follow-up visit we have to do the general examination, systemic examination, include the per speculum examination, the local examination of the vulva, as well as the perineal area. And once we have taken the biopsy and the biopsy is negative for malignancy, then definitely we have to counsel the patient and discuss the available options. Like we have initially done the skinning vulvectomy. So in this case, definitely involve, and the
You have to
disease
little bit more aggressive here. You have to little bit more
yes,
aggressive because the patient is complaining. She
yes,
is suffering from last 3 to 4 months with the recurrence, and
yes,
sees what treatment you did in last time. Again, I have the recurrence. So she
yes.
shouted out. So
So
need more
definitely
aggressive
surgical
kind of treatment. So
option.
we
I will advise total vulvectomy in this case for her,
total
because
vomiting, it will be actually it will be too
it will
radical,
be
I think, for this
too
treatment. But
radical.
so what we did with this patient, we evaluated the patient vulva and vagina. There was no estroid area. For speculum, cervix was not visualized here because it was cicatrization of cervix. And we found that there is what we did is the excision of the clitoral lesion and took multiple punch bags from the various the 4 to 5 lesions. And we took also anal smear because that is also very important. This is a message to the audience today.
The
Many times
treatment
there
will,
is a hidden lesion in the anal canal also. So at the same time, you never forget to take the anal smear. And here we could not take the pap smear here. So what we do is this excision of the clitoral lesion along with biopsy from other lesions. Now the clitoral growth lesion, whatever took the biopsy, that came to a VIN3 with no evidence of invasion. There is no invasion because radical kind of surgery will be definitely too radical for this type of lesions because I don't think there is a too radical. So what we did is again we found anal smear was normal, so other things are fibrosis, other lesions are.
sir, in this case, I will just take your like if all the lesions will be positive, then definitely we have to offer total vulvectomy. But since the
But
slide
other
shows
lesions are
they are,
but
yeah,
other
other
lesions are
lesions are
negative.
negative, and only the clitoral lesion is there. So definitely we can option the patient medical or the medical management or the ablative management, and or we can keep the patient on follow-up also, depending with the for the size.
And the 1 into 1 centimeter lesion near clitoris, actually, there really is suspicion. Need to do kind of excision of type of things. What do you need?
Yeah, wide local excision can be offered.
Yeah. So, question to Dr. Vinota. Vinota, are you there? So, how often you encounter recurrence in your clinical practice in such type of pre-malignant disease of vulva? Dr. Vinota?
Yeah. So, if it's vulval HSIL, the chances of recurrence is high, but not as high as DVIN. Because we also have to be careful about recurrence in the cervix, recurrence in the vagina, recurrence in the anus. A good clinical examination is usually important. Again, the risk of recurrence is also high in those who have had margin positive excision.
Yeah. So between this vulval HCL and DVN, so you have seen that many studies also shows that for vulval HCL it is a slow recurrence comes little later compared to DVN, which is come where the recurrence come very earlier also. That is so many literature says. And also if you have found the literature, it is mentioned that 1/3 of the patients develop recurrent vulval HCL regardless of the treatment and have a residual risk of developing invasive cancer in order of 2 to 4%. And up to 25% of women diagnosed with VIN will have intraepithelial neoplasia and other lower genital tract. So rightly mentioned by Dr. Vinota, you need to examine all the sites along with, never think that it is vulvar lesions, we will not examine the cervix and anal canal. It's not like that. So all the surrounding areas need to be more vigilant while dealing such cases. And coming to DVN, carries a higher risk of progression to malignancy up to 50% and recurrence also. That would keep in mind while dealing such cases. So Dr. Prashant, are you there? So what are the risk factors for the recurrent disease? What are the common risk factors for recurrence?
So most important are if the previous margin was positive with this,
Yeah.
then there is always a risk factor. Then others are
Yeah.
like immunosuppression habits such as smoking and other tobaccos. Other habits will
Yeah.
always increase the risk. And plus, if there is a multifocal, like what you have suggested in your case, there were some vaginal lesions also which you had taken
Yeah.
biopsies during the first procedure. So definitely you have to look into the vagina properly and anal canal as you have suggested very well, because sometimes there might be some hidden lesions there and we can later on get these recurrences. Plus, if the sizes are large, multifocal, multicentric lesions, then there is always
Yeah.
plus age factors and
Yeah.
immunosuppressions because
Yeah.
of
So
various
rightly mentioned
reasons.
by Dr. Prashant. Actually, if you have a more positive margin, you need to be more vigilant. Along with that, if there is a multifocal, multicentric disease and signs of immune suppression are there. So again, we follow up in January 2020. There was a satellite lesion in the perineum and perianal area. Examined every part of this vulval area and surrounding structures, and we found that there is lateral regression and no acetohide area was there. We follow up in November 2024. Again, this was normal. So now the question is, what next? If such scenario you treated the recurrent disease, patient, is there any definitive treatment for options and how to counsel the patient? That is very important because patient, when the recurrence, it is very difficult because once there is a margin positive, they read Google's. Margins positive are more prone to develop again recurrence. So, but we, as per evidences, sometimes if there is no invasion, we do not go for re-excisions. So so it is very difficult to counsel patients. So follow up and how long you follow up, and is there a role of corticosteroids to prevent recurrence? Dr. Vinod.
Sir, the follow-up definitely will be lifelong because the patient
We are
is.
coming to counsel, how to counsel the patient. That is very important.
Yeah. See, such patients, especially with the recurrence, they are at they are, their morale is low. So definitely the counseling is with the patient, husband, and preferably a joint counseling with a gynecologist, psychologist, or psychiatrist. And it's basically a team counseling, and where we have to tell the patient that till now, after so many years, you have not, there is no malignancy. That is good part, though the recurrence is there, but definitely the treatment options are available for the treatment is there, and a close follow-up is definitely required, and at a frequent interval, not as we can
And
do
how
on
long?
annual basis. And sir,
Patient will ask how long?
so generally, I will a lifelong surveillance. I will follow up. I will advise to the patient, and since in this case the lesion is regressing, and after 1 year, the lesion has not progressed. So definitely, I will put this patient on close follow up, and with every follow up visit, so all the uh, examination like general, starting from general examination, systemic examination, local examination, for speculum examination, include the anal examination, I will do at every visit. And
Yes, rightly mentioned. Go on, please continue.
regarding the role of corticosteroids, actually, the role of corticosteroids is not very clear in case of treatment modalities for recurrence. But however, various studies they have said that if the disease associated like lichen sclerosus, lichen planus, if that is there and it is well controlled with the topical steroids, so
Yeah,
definitely
yeah.
the
So
topical
which steroid
steroids.
you usually prefer? Which steroid can you name? Which steroid you usually prefer?
Sir,
You usually practice.
we can use
Usually we
a
use clobetasol propionate and the percent of
clobetasol
0.5
we
per
can,
0.
and patient must continue with topical steroid.
Yeah. Yeah, so right as rightly mentioned, you need to have, even the patient have the regression, but you have to counsel the patient in such a way that again he may reoccur again in the life. So he needs a, she should not be happy enough happy. She should be happy, but I think she should not be extra happy. And whether he should come for lifelong surveillance, that is required for this, particularly for HPV related carcinoma, that is required for convalescing. So with this, I think thank you so much, all the panelists, for your expert comments. And thank you, organizer, for giving me the opportunity to moderate these sessions.
Thank you, sir.
I think.
Thank you, everyone.
Thank you. Thank you. So over to Dr. Harshad and the ICOG team.
Thank you, Dr. Ashok, and the panelists, Dr. Vinod Dalal, Dr. Vinodha, Dr. Prashant Nyati, and Dr. Sampada, for being part of this panel.
Thank you, sir.
Thank you very much. Now, I think
Thank you.
we would like to proceed to the post test.
Sir, can I share, sir?
Yes. Yes, Shreya, please do share the forms
Yes, sir.
and let them take the post test.
ठीक है
It's the last 10 seconds left. Is everybody done? Please submit the forms. All of you all, please submit the forms.
Sir, can I share the answers, sir?
Yeah, 1 minute. Likita?
Oh,
Yes, sir.
Yeah. Yeah, please share the answers.
yes, sir.
So Likita can read it out.
Yes, sir. So starting with first question, what is the primary role of preoperative imaging in endometrial cancer management? The answer is D. To create a preoperative roadmap that dictates the type of hysterectomy, need for nodal assessment, or potential neoadjuvant therapy. Second question, a patient has a new diagnosis of grade 3 endometrioid adenocarcinoma. Her pelvic ultrasound is equivocal regarding the depth of invasion. What is the most appropriate next imaging modality? Answer is C, MRI pelvis. Question number 3. What is the primary clinical significance of determining if myometrial invasion is greater than 50%, that is stage 1B? Answer is A. The risk of lymph node metastasis increases significantly, mandating nodal assessment. Can you please scroll up? Thank you. Question number 4. A 65-year-old woman with endometrioid carcinoma shows abnormal p53 overexpression on IHC. Subsequent testing reveals a pathogenic exonuclease domain mutation. How should this tumor be classified? Answer is B, POL-E ultramutated. Question number 5. An endometrial carcinoma shows loss of MLH1, PMS2 on IHC. MLH1 promoter methylation is present. What is the appropriate molecular classification? Answer is B, sporadic MMR deficient endometrial cancer. Question number 6. 35-year-old lady presented with a 2 centimeter proliferative mass, stromal invasion more than 1 mm over the left labia majora, more than 2 centimeter away from the midline. No inguinal nodes are palpable. What is the preferred plan of management? Answer is A, wide local excision with sentinel lymph node biopsy. Question number 7. Indications of adjuvant radiation therapy in CA vulva are all except. Answer is D, involvement of even one inguinofemoral lymph node. Question number 8. What is the preferred dye used for sentinel lymph node detection in CA vulva? Answer is B, technetium 99 plus ICG blue dye. Question number 9. 66-year-old lady presented with a 5 centimeter vulval mass involving the posterior part of the right labia majora, anus and anal sphincter extending into the vaginal canal posteriorly. Bilateral inguinofemoral nodes are palpable. No distant metastasis on CECT whole abdomen and thorax. What will be the preferred mode of management? Answer is C, primary chemoradiation followed by excision of residual disease after radiation therapy. Question number 10. Management of micrometastasis on sentinel lymph node biopsy. Answer is B, radiation therapy, no inguinofemoral lymphadenectomy. Question number 11. Prerequisites for sentinel lymph node biopsy in vulval cancer are all except. Answer is B, stromal invasion less than 1 mm. Question number 12. What is the risk of lymph node metastasis in stage 1 endometrial carcinoma? Answer is 4, 10 to 12%. What is the risk of port site metastasis after MIS in endometrial cancer? Answer is 1, less than 1%. Question number 14. Which dye used for sentinel lymph node mapping in endometrial carcinoma? Answer is 3, indocyanine green. Question number 15. In which type of endometrial cancer omentectomy is required? Answer is 4, carcinosarcoma. Question number 16. When do you call it a postmenopausal bleeding? Answer is C, after 1 year of menopause. Question number 17. Diagnostic tools for postmenopausal bleeding. Answer is option D, all the above. Question number 18. Screening for endometrial cancer is justified. Answer is D, all of the above. Question number 19. A cutoff threshold of endometrial thicknesses in postmenopausal bleeding generally is? Answer is B, 4 mm. Question number 20. Following findings warrants management of postmenopausal bleeding. Answer is D, all of the above.
There is a small correction in that answers. All those who have given answer for in which of these omentectomy is needed, I think even clear cell carcinoma, that answer is also correct. So even that we will give correct. So thank you everybody. Likita?
Yes, sir.
Yeah.
Thank you to all the chairpersons who have assisted today and all the speakers of this session.
Yeah. So thank you. Thank
We
you.
are very grateful for the time you have given. And it is a very good learning opportunity for the PG students, post-PG. We are all very thankful for this certificate program.
Yeah. So thank you everybody. Thank you. I can see Dr. Anjana still there till the end. It is great to see you till the end. Thank you very much. Thank you, Dr. Parag Biniwale, the chairman ICOG, and Dr. Sarita Bhalerao. Sarita just called me up to say that she had a case and she had to rush. So she's asked me to take over. So thank you everybody. And I think soon you will be also given the result will be out, and in 3 days they will see the results for all the 3 days and give you the certificates. At least you must get 50% marks in all of them. So thank you everybody.
Thank you, sir.
Yeah, thank you.